Assalamu alaikum wa rahmatullahi wa barakatuh. Today, I am very happy to announce for the beginning of the seventh annual webinar for internal medicine from Saudi German Hospital, Riyadh branch. And the best thing to start with is some ayat from Quran. Assalamu alaikum. Today, I would like to start the seventh Saudi German Hospital Riyadh annual internal medicine webinar. I am with you for the next 3 days. I am Dr. Ahmed Al-Ghitani. I am head of internal medicine department and nephrology consultant. Our webinar for doctors who attended with us before, it is 3 days. Each day is 2 sessions, and each session is under some subspecialty of internal medicine and contain 4 or 5 presentations. So we have 6 sessions, 2 sessions every day: gastroenterology, hepatology, nephrology, pulmonology, and hematology and infectious diseases. Each presentation will be around 20 to 25 minutes, and we will have a session for question and answer for the rest of the 30 minutes for each presentation. And also by the end of the day and the end of the conference, we have evaluation form. I hope everyone to fill this evaluation form to have the full registration and full attendance for the webinar. CME hours, it is 21 CME hours, and it will be added for those who have the full registration and payment. And also for any inquiry, you can contact our organizer, Mr. Tamer Ahmed, and this is his phone number. Thanks for all the attendance, and I'm very happy that we reached around 600 participants. Thanks for all who attended and supported us. Now we will be presenting the first session. The first session with subspecialty of gastroenterology and infectious disease. And we will start from USA, from Mayo Clinic. We are happy to have Dr. Mariam Mahmoud. Thanks, Dr. Mariam, for being with us. Dr. Mariam is a consultant in the section of infectious diseases, Division of Public Health, infectious diseases and occupational medicine. She is also assistant professor of medicine in Mayo Clinic College of Medicine and Science. Thanks, Dr. Mariam. And please share your screen and share your presentation with us.
Can you hear me? Good morning.
Good morning.
Hi, can you hear me? Okay, great. Can you see my slides? Are they in the correct view?
They are not in the slideshow view.
Okay. Now?
Not yet. I see that you hit from beginning. Did you?
How about now?
Dr. Mariam, I can see your screen. Just press on full screen and start your presentation.
Okay. So for my screen, it looks like I'm starting my presentation, but is that not the screen that everyone's seeing?
Perhaps there is a delay, but because we are seeing the on the left, we are seeing the other slides. Are you seeing a full screen on your end?
I am, yeah,
Okay.
and I'm only on a
Okay.
single screen computer, so.
Okay. Well, there might.
Am I
maybe
in
there's just
presenter
a-
view on yours?
I am seeing your slides off to the left. I'm not seeing the full screen, but perhaps there's
Okay.
just a delay. Oh, are you going to reshare?
I am, yeah.
Thank you.
Okay, how about now?
We're still not seeing the full screen, but you know what? I think
All
that's okay. I
right.
mean, we obviously can see, you know, you could probably just start and scroll down on each presentation. And I mean, we can see the presentation, so I think it's okay. But now it's minimized a little bit. Yeah, go ahead.
Okay,
There,
apologies.
better. There we go. That's better. Thank you.
But this is still in the PowerPoint view.
It is, but it's minimized to the left. So I think we could go ahead. We can
Okay,
see
all right.
your main screen very well. So
Okay. Apologies for the technical difficulties. I'm Dr. Mahmoud. I'm one of the infectious disease consultants. I'd like to thank the organizers for inviting me to speak today. It's morning in Minnesota, but I understand afternoon in Riyadh. Today, I'm going to talk a little bit about imaging of cardiac device infections, and this is a little bit interactive, so please let me know if you have any questions along the way, and there's going to be some questions as well for you. So feel free to unmute and answer or put your answers into the chat, whatever the organizers prefer. So we're going to start off with a question of a 67-year-old man who was transferred to you with 5 days of persistent Staphylococcus aureus bacteremia on appropriate antibiotic therapy with oxacillin. He has a background of prior VT arrest and has a ICD, a cardiac defibrillator placed for secondary prevention. Has a history of CAD, having had a CABG in the past, and aortic stenosis, having had a transcatheter aortic valve replacement in the past. So he comes into you with this bacteremia of unclear source. He has a TEE, a transesophageal echocardiogram on day 1 and 4, which is negative for any lead or valvular endocarditis. What do you feel is the next best step in management here? To repeat another TEE in a week, to get a PET CT, to change antibiotic therapy to daptomycin and ceftaroline, given the persistent bacteremia, to get a cardiac CT, or just to remove the cardiac device? And I'm not sure if interaction in the chat is possible. And I also can't see the chat now in this current view. Mary, are there any responses at all?
Not at this time.
Okay, I'll continue. So there's a few approaches that you can take in this case of persistent bacteremia of unclear source with negative TEE. You can either get a PET CT or a cardiac CT. And we're going to talk about how this differs from the traditional approach to cardiac device infection evaluation and the newer imaging modalities around how we can better visualize infections of these devices. So cardiac device infections can involve the generator pocket, the device leads, the valves, or a combination of these sites. And when they involve the generator pocket infection, which you can see over here in this diagram, it's generally a more obvious site of infection. So you typically have erythema, swelling, pain, incisional dehiscence, drainage, and sometimes the device itself or the leads can erode out. So this is a fairly obvious sign of infection. The more challenging scenario is when you have bacteremia or non-specific systemic symptoms, fevers, malaise, or you incidentally see lead or valvular vegetations on an echocardiogram. And here it's a little bit less clear how we can best evaluate for cardiac device infections, particularly in the portions of the cardiac device that aren't directly visible. So the leads, the intracardiac portion of the leads as well. So we know that there's certain risk factors for cardiac device infections, and we know that overall cardiac device infections are on the increase. The risk factors for cardiac device infections really are around direct pocket manipulation, so trauma, or a generator change. People on anticoagulants after a generator change may also be more likely to form a hematoma and potentially increase the risk of infection from that perspective. Bacteremia, particularly with organisms that have a propensity to seed endovascular hardware, may also put you at higher risk of seeding of the intracardiac portion of the leads of these devices. Other typical risk factors are chronic kidney disease, chronic heart failure, diabetes, use of steroids, and there's also procedure-specific factors. You know, the number of device revisions, it puts you at higher risk of infection, the need for temporary pacing, and as I mentioned, anticoagulation, all may increase your chances of cardiac device infections. So we know that these are increasing, and we know that they can be challenging to diagnose if it's not an overt pocket infection or an incisional infection. So our traditional approach to diagnosis of cardiac device infections when the clinical findings are equivocal or less clear has been anatomic imaging, largely around echocardiography. Cardiac CT and cardiac CTA are two other modalities of anatomic imaging that may be used. But we're also going to talk about functional imaging, which is a newer imaging modality for evaluation of cardiac device infections. And this largely focuses around nuclear imaging, PET CT, and leukocyte scans. So this is a diagnostic algorithm from the cardiac device infection guidelines in the United States from the American Heart Association, published in 2010. And they outline that for a suspected cardiac device infection, where you have negative blood cultures, you can define it as either a pocket infection or as generator lead erosion. Generator or lead erosion, you can treat with a shorter course of antibiotics after device explantation. Pocket infection, you can treat with a 10 to 14-day course of pathogen-directed antibiotics, oral or IV, whatever is available for that organism, but again, with device explantation. So the big picture here is that if there's a confirmed device infection, then explantation is typically recommended because there's a higher chance of relapse if the infected device or exposed device is retained. For superficial incisional infections, which aren't demonstrated on this particular diagnostic algorithm, you can retain the device and try and treat with a course of antibiotics to try and salvage it. So that's for the individuals who have negative blood cultures and suspected device infection.
Dr. Merriam, there
Yes.
is one comment that says, in many cases, we see sepsis in patients with intravenous catheters like CVPs or dialysis catheters in patients with cardiac devices, and patients improved with plastic device removal and antibiotics. I just wanted to make that comment.
Thanks, Mary. So for those who have positive blood cultures or who've received prior antibiotic treatment, in which case blood cultures may be rendered falsely negative, the next step in evaluation for suspected cardiac device infection is a transesophageal echocardiogram. So this is where you can define whether there's a valve vegetation, lead vegetation, or if there's nothing visualized on the TEE. And this will help define what you do with the cardiac device. And to be clear, for the purposes of this talk, when I say cardiac device, I'm referring to pacemakers, implantable cardiac defibrillators, those sorts of devices, and the traditional pacemakers rather than leadless pacemakers also for the purposes of this talk. So on the transesophageal echocardiogram, if you visualize a valve vegetation, then the recommendation is to follow the treatment guidelines for infective endocarditis. If there's a lead vegetation, then the treatment is defined on whether it's complicated, in which case a 4 to 6 week course of typically IV antibiotics is recommended. If it's uncomplicated lead vegetation, then it gets managed depending on what the organism is. And here we see that whether it's Staph aureus or whether it's a non-Staph aureus organism, defines how long we do antibiotics for. This is because Staph aureus in particular is a very virulent and common cause of cardiac device infections. It has a strong propensity to form biofilm on endovascular hardware, and therefore a longer course of antibiotic treatment is recommended. Again, this all includes explantation of the cardiac device, which can be costly and carry morbidity for the patient. So it's important for us to really be confident that we're diagnosing a true cardiac device infection in the context of this side of the diagram, where we have suspected device infection without overt pocket symptoms. So how effective really is echocardiography, the typical mainstay of diagnosis for valvular endocarditis? So TTE for native valve has a pretty decent sensitivity, around 40 to 70%, less so for prosthetic valve endocarditis. Transesophageal echocardiogram is really the recommended first-line test if you have a high suspicion for infective endocarditis or if you have prosthetic valves. Its sensitivity is great for native valve endocarditis, but again, much less sensitive for prosthetic valve endocarditis. And this is partly because it may be down to operator proficiency, but also the prosthetic valve in and of itself can have acoustic shadowing around the ring, complicating imaging of that area well. The bonus of echo is that it can detect valvular vegetations and perivalvular complications like leaflet perforation, fistulas, pseudoaneurysm, or valve dehiscence. There's also some data that the nature of the vegetations, the locations on an echo may be able to predict embolic events, which is important for people who have infective endocarditis. So the next anatomic imaging modality that is being increasingly utilized for evaluation of endovascular infections is cardiac CT or CTA. Again, more typically for valvular endocarditis. This has excellent spatial resolution. And in prosthetic valve endocarditis, there is data to suggest that its accuracy may be on par with TEE. So in a study of 28 patients, additional use of cardiac CT led to a change in treatment strategy in about a quarter of patients compared with routine clinical workup. And depending on the quality of the study, you may be also easily able to detect pseudoaneurysm, abscess, prosthetic valve endocarditis, or valve dehiscence. It is important that for a cardiac CT to have good image quality, it needs to be synchronized or ECG gated with the patient's heart rate and rhythm to reduce the amount of motion artifact. So keep in mind that for people who are tachycardic or have an irregular heart rhythm or tachypneic, this may not be ideal. So when we look at echo for cardiac device infections specifically, really all you can visualize on that is the intracardiac and the initial SVC segments of the device leads. So it is limited visualization of the device leads, the intracardiac portion. And it can be challenging to differentiate just benign or bland thrombi or non-infected vegetations from infectious vegetations on echo when you find these. We know that in other studies, thrombi are pretty commonly found incidentally on device leads. So TEE is generally more sensitive than TTE at looking at tricuspid valve involvement, lead vegetations, and left-sided cardiac valve involvement. TT allows for evaluation of pulmonary pressures, effusion, or LV function, so it has some other purposes. But importantly, the negative echo doesn't rule out cardiac device infection because of these limitations. When we look at just plain CT imaging for cardiac device infections, you may be able to see some nonspecific local inflammatory changes or abscess of the generator pocket, but in a recently placed device, it may be challenging to differentiate just sort of placement-related inflammatory changes versus infection changes. The bonus of CT, though, is that you might also be able to detect distant septic emboli. So, for instance, if you do an MR of the brain and you see multifocal emboli, you're suspicious for endovascular infection. Also, pulmonary embolic complications or mycotic aneurysms are also other things that may guide you towards a diagnosis of endovascular infection. Obviously, though, on a CT, the metallic artifact around pacemakers and other cardiac devices impacts substantially on image quality, and it's less sensitive as an evaluation for small valve or lead vegetations compared to echo. So, in summary, anatomic imaging for cardiac device infections and endovascular infections may be able to detect late structural changes from infection, but findings can be nonspecific, particularly in the early period after device implantation. And visualization can also be complicated by artifact from prosthetic material on both cardiac CT and echo. So this is where functional imaging really comes in. So this is why we're increasingly using functional imaging, typically nuclear imaging in the form of a PET CT or a tagged white cell scan, to better evaluate for cardiac device infections. So let's talk about PET CT first. So PET CT is, for the purpose of cardiac device infections, is with 18-FFDG, fluorodeoxyglucose. And the bonus of this is that you can visualize both the intracardiac and extracardiac parts of the device, looking for lead infection, device-related endocarditis, or pocket infection that may be less clinically evident. For generator pocket and extracardiac lead infection, it's highly accurate and has a high negative predictive value. For lead endocarditis, it has a high specificity but lower sensitivity based on the data we have so far. And the other big bonus of PET CT here is that it's a whole body image. So in our institution, we typically do sort of a head to thigh imaging. So you can see other sources of potential infection, malignancy as a source of systemic symptoms. You can also see secondary foci of infection like psoas abscesses, septic arthritis, vertebral osteomyelitis. So it sort of gives you a whole body image of the patient that may support your diagnosis of endovascular infection or provide you with an alternative diagnosis to explain the symptoms or bacteremia. For PET CT, though, when we're talking about cardiac device infections, we really have to optimize the image quality to ensure that we have good diagnostic accuracy. The small lead vegetations can be limited by the spatial resolution of the PET CT, as well as by cardiac and respiratory motion artifact. There's robust data to suggest that suppressing physiologic myocardial activity, same as you would do for visualization of cardiac sarcoid, is the best way to get good image quality for these small lead vegetations. So this typically involves fasting for at least 4 to 6 hours, and also having a ketogenic diet, essentially a high-fat, low-carbohydrate diet for at least 12 to 24 hours before the imaging. Blood glucose optimization is important. And in some studies, IV heparin given 15 minutes prior to FDG administration has also been shown to decrease the amount of physiologic myocardial activity. The intention of all of these measures is really to decrease blood glucose, decrease insulin, and sort of convert the myocardium to using ketones rather than glucose for fuel, so that when you give them FDG labeled glucose, it's going to go to areas of infection or inflammation rather than to the myocardium. Activity restrictions, so typically we ask people not to do any rigorous activity for 24 hours before the scan, is also important here. Imaging for And PET-CT imaging is typically performed at 60 minutes after FDG administration. So this is kind of standard from malignancy imaging. But there is a cardiac device infection specific data that suggests that delayed imaging at 90 minutes, 180 minutes may better visualize some of these smaller foci of infection as sort of that physiologic myocardial glucose is washed out. Motion correction methods with respiratory and cardiac gating are also helpful, as are attenuation correction methods. When you're looking at PET-CTs for cardiac device infections, there's a few ways to look at it. Visual analysis is the most common. So you look at the degree of FDG avidity and the distribution pattern. There have been a lot of studies attempted to better use a semi-quantitative analysis, similar to what's done for lymphoma or other malignancies, to try and get a cutoff value for optimal diagnostic accuracy. But it's been hard to get a uniform semi-quantitative ratio or value because it's really impacted by the scanner, the processing, and the local procedures. So this is still an area that's kind of in flux here. And here's an example of infection around a cardiac device. So where you can see my mouse on the screen here, you can see that there's kind of heterogeneous uptake rather than homogeneous uptake all around, with focal increased activity and typically at the junction of the leads in the device and then extending into the subcutaneous portions of the lead and then into the intracardiac portions of the lead here as well, is classic for cardiac device infection. In inflammation, you can, especially shortly after, in the first month or so after device implantation, you may see some homogeneous, mild circumferential uptake around the generator device itself or even around the leads, but less so. The other caveat to know on PET-CT evaluation for endovascular infection is that prosthetic material can also light up when uninfected. And classically, this is a surgical adhesive when it's used for mechanical valves, and Marfan's repairs are sort of the classic ones. And this kind of low homogeneous uptake around surgical adhesive and endovascular prosthetic material can persist for 12 months or longer, but typically tends to be most intense around 6 months. So there are limitations of PET-CT, just as with the diagnostic modalities for cardiac device infection. We know that the results may be impacted by prior antimicrobial therapy. So if you've treated someone for presumed cardiac device infection with a prolonged course of antibiotics, that may lessen the degree of FDG avidity and the diagnostic accuracy of your PET scan. Also, recent surgery or device implantation within a few months of any of those activities may make the interpretation of these images challenging. Spatial resolution of PET-CT scanners is also important. And the preparatory and image processing protocol, while there's good data for some measures, the optimal processing has yet to be defined. Cost and accessibility, depending on where you practice, are also important here, as PET-CT scanners aren't readily available or covered by insurance providers everywhere. As I mentioned, secondary foci of infection is another helpful way to use a PET-CT for endovascular infection. You can find extracardiac foci of infection earlier and address them earlier. So if you find an intramuscular abscess or a visceral abscess, you can address that earlier. If you find vertebral osteomyelitis, that may adjust your duration of antibiotic therapy. And it's very common in PET-CT to find some sort of septic emboli, whether in the spine, in viscera, septic arthritis, in a vascular graft, or is in the lungs. And there's data to suggest that treatment is modified based on these findings in about a third of patients, whether with prolonged antibiotics or need for surgical or procedural intervention. So I do have a case here of an 87-year-old man with Staph lugdunensis bacteremia. So Staph lugdunensis is a coagulase negative bacteremia. And typically we think of coagulase negative bacteria as less pathogenic and less virulent than Staph aureus. But Staph lug is one of those coag-negative staph that's almost as virulent as Staph aureus, and certainly in its propensity to cause infection of prosthetic material, specifically endovascular material. It has very similar virulence properties to Staph aureus, so important to recognize that. So this particular gentleman had a bioprosthetic aortic valve and a pacemaker, and also underwent bilateral subacromial joint injections for rotator cuff pain. He had a TEE and a TTE, which was bland. So he went on to get a PET-CT, which really nicely demonstrated FDG activity at the prosthetic aortic valve, at the shoulder, at the sub-Q joint, at the SC joint, the sternoclavicular joint, and also the left second toe, but nothing at his cardiac device up here. So he underwent IND of the shoulder, his toe was amputated, but his prosthetic valve and his pacemaker were retained due to age and comorbidities. He completed a course of cefazolin and then transitioned to chronic doxysuppression. Because of his age, no other intervention was performed. So that's how PET-CT can be helpful in looking for cardiac device infections. And in our institution, we largely prefer PET-CT to tagged white cell scans because the turnaround time is faster, you get better image quality, and tagged white cell scans typically involve transfer of white cells and then labeling and then infusing back into the patient. So it tends to be a little bit more cumbersome, again, with a longer turnaround time. And depending on what you're looking for, the early or delayed images may be what you're looking for here. The difference between tagged white cell scans and PET-CT is really that PET-CT is more sensitive for endovascular device infection diagnosis, and tagged white cell scans are probably more specific, particularly in the early post-implantation period or early post-surgical period. Tagged white cell scans should probably be your diagnostic test of choice when you're looking for device infections. So again, here you can see demonstrated visually that tagged white cell scans compared to PET-CTs, there's differences in image quality and specificity. And again, tagged white cell scans probably more useful in the immediate period after valve replacement surgery or cardiac device replacement compared to PET-CT. You do need blood handling, you have a longer turnaround time, and somewhat less optimal spatial resolution as compared to PET. Both, though, increase diagnostic accuracy, particularly in possible device infection. So for rejected or definite cardiac device infection, these nuclear imaging or functional imaging modalities probably aren't going to change what you do. But in those who fall into the possible device infection bucket, these probably are going to impact on your sensitivity and specificity and being able to reclassify people as not device infection or definite device infection. I think we'll skip over this in the interest of time. So this is an algorithm from the European Cardiac Device Infection Guidelines published in 2020, and it outlines how you can utilize these other imaging modalities that we've talked about. So again, in the context of negative blood cultures, where you have a definite pocket infection, you just go down to the extraction and appropriate antibiotic therapy part. In those who have a negative pocket exam, so no clinically evidence of pocket infection, but you're highly suspicious, or there's no obvious pocket infection, but a positive blood culture, or even with a pocket infection, then you can consider additional imaging with PET-CT or tagged white cell scan. And it will also help you image for embolic events. And then that will help define what you do in terms of antibiotic therapy, removal of the device, etc. So we've talked about anatomic imaging, the typical use of echo, as well as additional helpful adjunctives like cardiac CT or cardiac CTA. We've also talked about how functional imaging can help with better visualization of cardiac device infections in particular. And there is some emerging studies on bacterial and infection-specific radiotracers. Some of this has been studied for decades, and really nothing has come out of these clinical studies. There's been tagging of antibiotics and bacterial antigens and all of these things to try and get a bacterial or infection-specific radioisotope. And really nothing much has progressed into the clinical trial stage. So there have been some more recent trials with Staph aureus specific radiotracers, And we're hopeful that those and other modalities will be helpful in getting us more specific imaging for infection with nuclear imaging. But again, we think that prior antibiotic therapy, when it kills bacteria, may impact on these bacterial specific tracers, compared with FDG, which also reflects the host immune response, so may still be able to give us an answer despite prior antibiotic therapy. So that is the end of my talk. I'm happy to answer any questions at this time.
Thanks, Dr. Mariam. We are very happy to have this presentation from your side. I will list the questions just right now. Sure. Our first question, as PET scan very effective in inflammation diagnosis, why is still radiology not convinced and struggle to do it in inflammatory condition? So I think the question, can you trust PET scan only without doing the cultures and sepsis marker?
No, for sure not. Because, I think inflammation is a big pocket. And if we focus just on when people get referred to an infectious disease physician, for instance, it's typically when they have non-specific systemic symptoms, and PET scan can be a useful adjunct in that context, but you still need to do an appropriate clinical evaluation for symptoms, exposures, and do an appropriate microbiologic and infectious disease evaluation. Obviously, if their symptoms point towards an inflammatory condition, a rheumatologic or immunologic condition, or even malignancy, then a PET scan may also be a helpful adjunct there, because you may be able to visualize vasculitis changes, inflammatory bone changes, or arthritis changes. So I think it's a useful adjunct, but not a standalone.
I think also we can use PET scan to find other septic process. It may not only limit it to the cardiac device, but also to some other wares, like septic emboli everywhere in these kind of patients.
For sure. So in our experience, when we do these imaging for Staph aureus bacteremia and someone has a cardiac device or a prosthetic valve and we're looking for infection of the endovascular infection, we'll very commonly find septic emboli on the spine or septic arthritis that's not obvious clinically quite yet. Or we'll find psoas abscesses or visceral abscesses. So it's very common for us to find additional sites, which we can then clean up earlier, right? So you can have the joint washed out earlier. You can have the psoas abscess drained earlier. We've had good instances where we've done a CT and then a PET CT, and it's had much better visualization of prosthetic septic arthritis or of psoas abscess than the non-con CT or contrast CT has.
Okay, the other question, can you depend only on PET scan to diagnose infective endocarditis with negative blood culture?
I think unfortunately not. Every imaging modality for anything, you have to be aware of its limitations, its sensitivity, and its specificity. And particularly for infection-related imaging, you should be aware of the impact of prior antibiotic therapy and what the organism may be. We know that certain indolent or organisms that cause subacute infective endocarditis, you may see less FDG avid changes. The valve changes may look different on echo. So you kind of have to put that all into context when you're interpreting these imaging and diagnostic modalities together for endovascular infections.
Okay, what is the incidence of cardiac device-related infections?
Oh, that I don't know off the top of my head, sorry. Yeah.
Okay, the last question. 1 minute. Safety of cardiac devices with MRI.
It depends on the type of device, and a bit beyond my scope as an infectious disease doctor, but it does depend. Some of the newer modalities, you can have a physicist there and help manage it. Some of the older devices aren't MRI compatible, so it just very much depends on what kind of device you have.
Okay, thank you, Dr. Mariam, and we wish to see you in other webinars. And it was so nice to hear and see your presentation and attend the question and answer.
Okay. Thank you again for the invitation.
Can you please stop sharing your screen, right?
Yes, I have.
Okay, thank you. And now, with the second presentation, we have Professor Imad Turki. Professor Imad is a professor of gastroenterology, hepatology, and gastrointestinal endoscopes And also he's the chief of gastroenterology department in Saudi German Hospital, Cairo. Dr. Ahmad Turki is well known in Egypt and Saudi Arabia. He was one of the pioneers of endoscopy during the first ERCPs in Saudi Arabia and also in Egypt. Assalamu alaikum, Dr. Ahmad.
Alaikum salam wa rahmatullahi.
We are very proud and very happy that Dr. Ahmad is giving us this honor. He was ex-head of department of internal medicine here in Saudi German Hospital, Riyadh, and also in Asir and Jeddah, and currently in Cairo. Professor Ahmad will talk today about cystic lesions of the pancreas. Thank you, Dr. Ahmad, and we can see your screen.
Thank you very much, Dr. Ahmed, for this nice presentation and introduction. I would like to thank the organizing committee for giving me the chance to share this prestigious symposium. My topic is a little bit tough topic about the cystic lesions of the pancreas. I hope I can make it a little bit easy. Ramana? Cystic lesions of the pancreas can be classified into non-neoplastic, which is the most common, including the pseudocysts, and some uncommon cysts like the retention cyst and simple cysts, and neoplastic cystic lesions like the serous cystic neoplasm, mucinous cystic neoplasm, intraductal papillary mucinous neoplasm, and I will call it serous neoplasm, mucinous neoplasm, and intraductal neoplasm for simplicity. Less common neoplastic cysts, including the solid pseudopapillary epithelial neoplasm or SPAN, and tumors showing cystic degeneration like adenocarcinoma and neuroendocrine tumors. Now, the mucinous cystic neoplasm and the ductal cystic neoplasm and the SPAN have malignant potential. The epidemiology, these lesions are more frequently discovered during the last years due to the wide use of the advanced imaging techniques, and also because of aging of the population. And it's in most of the cases, the cysts are discovered accidentally. The prevalence in the general population, it's reported to be between 2.6 to 15%. And the prevalence is increasing with age. So for people more than 80 years old, the prevalence can be high, up to 37%. Detection, usually incidental detection by the imaging modalities, varies. In ultrasound, it's uncommon, it's the least sensitive, 0.2%. CT scan is better, showing the screening cases, usually 2 to 5% of cases can show the cysts. MRI is the best modality, and 14 up to 20% of cases you will find cysts in the pancreas. The malignant transformation risk is generally small. It's estimated that the annual conversion rate to invasive cancer is only 0.24%. But for the malignancy rate in the surgically resected cases, in a retrospective study, including 9 studies with 2,796 cases, the malignancy rate was 15%. While when include only the intraductal papillary mucinous neoplasm, through 99 studies, 9,249 cases, the malignancy rate was 42%. Now, these are the common characteristics of the pancreatic cystic lesions, including the pseudocysts, which are non-neoplastic, and the cystic neoplasm, the other cystic neoplasm. Pseudocyst is the most common, occurring in about 75 to 80% of cases. It affects any age. It affects both sexes. It affects any part of the pancreas, and it has no malignant potential. Serous cystic neoplasm is the next common. It's usually account for about 1/3 of the cases. Affect old people, usually between 50 and 70. We can say it affects the grandmother, affecting mostly the females. And in 50% of cases, it's in the body and tail, and the malignant potentiality is extremely low. Mucinous cystic neoplasm is the next. It affects about 1/3 of, it accounts for about 1/3 of cases, affecting middle-aged people, usually females, exclusively in fact, and mostly in the body and tail, and it has a high malignant potentiality, and we can say it can affect the mother. The intraductal neoplasm, whether affecting the main duct or the branch duct, they account about 1/3 of cases, affects both male and female equally, usually in the age of 60. It's mainly in the head of the pancreas, and it has a high malignant potential for the type affecting the main duct and moderate potential for the type affecting the branch duct. For the solid pseudoepithelial neoplasm or SPEN, it affects young females, usually in the body and tail, and it has a moderate malignant potential, but it's the least common. So for those neoplasm affecting the females, which is usually the case, the serous cystic neoplasm affect the grandmother, the mucinous cystic neoplasm affect the mother, and the SPEN affects the daughter. The serous cystic neoplasm has a very low rate of malignant potential. It's very extremely low. Mucinous cystic neoplasm has high malignant potential, and SPEN has a moderate malignant potential. The clinical presentation, in most of the cases, there is no symptoms. Abdominal pain, nausea, and vomiting are non-specific. Sometimes a patient presents with abdominal swelling, as some of the cysts can have a very large size. But when the patient presents with obstructive jaundice, which is related to the cyst, this is classified as a high stigmata of high risk stigmata for malignancy and an absolute indication for surgery. For patients presenting with the recurrent pancreatitis, which is common in the intraductal type, especially the main duct type, this is classified as worrisome feature for malignancy and a relative indication for surgery. The diagnosis will depend on some imaging and some laboratory tests. A combination of CT scan, MRI, and MRCP, and AUS with fine needle aspiration is usually needed before a reliable diagnosis can be made. While CT scan will give us an idea about the whole pancreatobiliary area and the surrounding organs, can also give an idea about stigmata for chronic pancreatitis, determine the enhancement for the neoplasm, and it is specific for and more superior than MRI for diagnosing calcification within the cyst. However, MRI and MRCP are the imaging modality of choice, being superior to CT in differentiation of the cyst type, identifying the communication with the pancreatic duct, identifying the solid component and mural nodules, and because also of its less radiation exposure. AUS and the fine needle aspiration is recommended as a second-line examination in addition to the CT and MRI in all cases when the radiological diagnosis for malignancy is not very clear or in the presence of a worrisome feature. Contrast-enhanced AUS should always be considered in the presence of mural nodules or solid component to assess the presence of vascularization. These are some cases, CT scan showing a mixed density lesion in the body of the pancreas, while the MRI is better showing the multicystic and microcystic pattern of the serous cyst adenoma. CT scan is showing the calcification in the center of the cyst. MRI is showing being multicystic, and the calcification is indicated as high dense lesion. Laboratory markers, CA19-9 is the only serological test used, and it can be high in mucinous cystic neoplasm and sometimes in the intraductal neoplasm. The rest of the tests are done through the cyst fluid itself after aspiration with fine needle. Amylase is always high in pseudocysts, sometimes in the intraductal cysts. Glucose specifically could be high in serous cystic neoplasm. CEA can be high in mucinous and intraductal papillary mucinous neoplasm, and a cutoff of more than 192 is used as a marker for malignancy. CA19-9 abnormal or higher level can be seen in also the mucinous cystic neoplasm and the intraductal neoplasm. Both, again, are stained positive for mucin, as they are secreting mucus and stained for mucin. KRAS and GNAS mutant gene mutation is very promising in the diagnosis of intraductal pseudo-mucinous neoplasm. Now, just a comparison between the pancreatic pseudocyst and the other pancreatic cystic neoplasm. Pseudocysts can be unilocular, usually unilocular, sometimes multiple. It can be present in any part of the pancreas. Usually there is a history of pancreatitis or abdominal trauma. The cyst develops in 4 to 6 weeks. Debris within the cystic lesion is a specific MRI finding, and fluid is rich in amylase. While for the pancreatic cystic neoplasm in general, all of them, the fluid is low in amylase. They usually have a thick wall, septations are common, there could be a solid component, pancreatic duct could be dilated, and there could be calcification central or peripheral. This is an example of a pseudocyst. It's DR2, and there is no real wall. This is an example of a serous cyst with central calcification, and this is another picture for the microcystic pattern. Now, some points about each cyst alone. Serous cystic neoplasm consists of multiple small, less than 2 centimeter cystic components arranged in a honeycomb pattern, and they have a lobulated surface. It could be microcystic, or in most of the cases, sometimes macrocystic or mixed and rarely solid. The microcystic type have a central scar in 30% and calcification in 18%. This is a nicely presented case by MRCP of a serous cystic neoplasm. And this is another CT imaging showing the multicystic nature and the central calcification. The mucinous cystic neoplasm usually is single or multiple. It can be unilocular or multilocular, but the loculi are larger in size, more than 20 millimeter, and less in number, usually less than 6. This is a bilocular mucinous cyst, and these are two cysts together near to each other with thick wall, and this is one cyst showing peripheral calcification. They may reach a high size, in fact. The intraductal papillary mucinous neoplasm, it arises in the main pancreatic duct or the branch duct. It's usually in the head, much more common than in the body and tail. Affects both male and female. It communicates with the pancreatic duct and can be multiple. And the main duct type has the highest malignant potential among all the pancreatic cystic lesions. And it can be associated with what's called fish eye ampulla, as it's obstructing the pancreatic duct. This is an example of a main duct neoplasm with associated with dilatation of the main duct. This is arising in a branch duct from the pancreatic duct, and this is both. This is the fish eye appearance. The papilla is stretched and some mucus secretions come out of it. The solid pseudopapillary epithelial neoplasm, it's almost exclusively occur in young females and is located in the body and tail in most of the cases. The classical CT appearance is a large, well-capsulated mass with solid and cystic components and sometimes hemorrhage. It has moderate malignant potential with more than 80% cured by surgical resection. This is an ultrasound example for combination of the cystic and solid components, CT scan appearance with enhancement of the cystic component, and MR appearance with much more better appearance of an enhancement of the cystic component. Now, before deciding for management, we have to risk stratify the cystic neoplasm. High risk features, which are absolute indication for surgery, include obstructive jaundice related to the cyst, dilated main pancreatic duct more than 10 millimeter, and the presence of enhanced solid component or mural nodule large in size, more than 5 millimeter. Worrisome features which deserve further workup, like AUS and fine needle aspiration, include the cyst size more than 3 centimeter, main pancreatic duct dilatation but less than 10, abrupt change in the caliber of the main pancreatic duct, enhancing mural nodule, thickened enhanced cystic wall, growth rate of more than 5 millimeter per year or 10 millimeter in 3 years, and high serum level of CA19-9 or the presence of regional lymph nodes. There are two exceptions for these indications for absolute indication for surgery or relative indication for surgery is for young patients with mucinous epithelial pancreas. Pancreatectomy or surgery should be discussed with the patient even if there are no worrisome features of high risk stigmata, just to avoid the lifelong follow-up. For SPEN, which affects young females and carries a moderate potential for malignancy, surgery is always advocated for such patients because of the malignant potential and because it is curative in about 85% of cases, and surgery is advocated regardless of the size of the cystic neoplasm. Now, there are 3 guidelines widely used from the American Gastroenterology Association in 2015, the International Association of Pancreatology in 2017, and the European Gastroenterology Association in 2018. In fact, there is no common agreement about the several things related to the pancreatic cystic neoplasm. For example, the American Gastroenterology Association discussed only pancreatic neoplasm discovered accidentally. The International Association for Pancreatology discussed only the intraductal type. The European discussed all the types of these cysts. There's also the risk stratification is not considered in the AGA guidelines. And surveillance is also, they recommend to stop it after 5 years if there is no change, but the European guidelines, advise to continue surveillance lifelong. So there is no real agreement on all the parameters. But there is agreement about the high risk criteria for malignancy, including the main duct dilatation, enhancing neural nodule or solid component, and the presence of obstructive jaundice. The 3 guidelines agreed about these are high-risk stigmata that deserves surgery. So in deciding about the management of pancreatic cystic neoplasm, if the diagnosis for pseudocyst or serous cyst is reached, no surveillance is needed, because of the pseudocyst has no malignant potential, and serous cystic neoplasm has a very low potential, 1 per 1,000. So there is no need for surveillance. But in general, for the other types, the malignancy is small. However, the presence of malignant potential represents a real challenge for the patient and for the clinician, as by the time pancreatic cancer is diagnosed, only 2% of the cases are resectable. So it's crucial for the clinician to identify patients with pancreatic cystic neoplasm deserving surgery before invasive cancer can take place, keeping in mind that the reported mortality and morbidity rates for such resected cases is in the range of 1% mortality and 30% morbidity. There are several variables to be considered related to the disease itself, related to the patient himself, related to the surgery. And at the end, the surgical decision should be tailored to all these variables. And in fact, the management should be, the decision for surgery should be individualized to each patient separately. Now, this is an algorithm or a pathway how to manage with the pancreatic cystic lesions with malignant potential. If the patient has absolute indications for surgery or the high-risk stigmata, which we mentioned before, including also a malignant cytology, then the patient has to go for surgery if he is fit for surgery. If the patient is not fit for surgery, then we can resort to AUS-guided radiofrequency ablation or paclitaxel injection. If the patient has worrisome features or a relative indication for surgery, which we discussed before, this patient should go for AUS and fine needle aspiration. If the suspicion is confirmed for malignancy, then he should be referred for surgery if fit. And if not confirmed, then the patient has to continue surveillance. And by continuing surveillance, if over the time there is no change, we keep continuing the follow-up. If the patient at any time develops worrisome features and also a rapid growth rate, then he has to go for AUS and fine needle aspiration. If he develops at any time high-risk stigmata, then he is a surgical candidate. And for those who will go for surveillance and follow-up, the follow-up depends on the size of the cyst. For small cysts less than 10 millimeter, CT and MRI are used for follow-up the first time after 6 months. And if there is no change, then we go for every 2 years follow-up. For cyst neoplasm size between 10 and again CT and MRI, but it will be bimanual every 6 months for 2 times. If there is no change, then we go for follow-up every 1.5 or 2 years. For cysts larger in size, it depends on MRI and AOS in the follow-up. And the follow-up for cysts between 20 and 29 millimeter will be bimanual for 1 year every 6 months. And then if there is no change, we continue yearly. For cysts more than 30 millimeter in size, the follow-up should be always 6 monthly. If at any time the patient will develop high-risk stigmata, then he should be a surgical candidate. If he develop at any time worrisome features or rapid growth rate, then he has to go again for AOS and fine needle aspiration. And according to the finding, either to go for surgery or to continue surveillance. I take home the messages. Pancreatic cystic neoplasm are uncommon, but becoming increasingly reported during the last years due to the advancement in imaging techniques and also in the population aging. The malignant transformation risk is small, but it increases by 20-fold for cysts more than 20 millimeter in size, being highest in the intraductal type, especially of the main duct. This is the highest rate or malignancy rate. It's high in mucinous cystic neoplasm, moderate in the intraductal papillary mucinous neoplasm, the branch duct, and also in the spen type, and extremely low in the serous cystic neoplasm. Surgery carries a mortality rate of 2.1% and a morbidity of 30%, and it's significantly higher when Whipple procedure is done compared to distal pancreatectomy. Surgery is advocated in young patients presenting with span or even with mucinous cystic neoplasm without worrisome feature if it's in the tail of the pancreas to avoid long-term follow-up. And if the decision for surgery is taken, it should be done in a high volume center to reduce the mortality and the morbidity rates. Thank you very much.
Thank you, Dr. Ahmed. Thanks for this nice presentation. We have 2 questions. The first question, following a surgery, how to manage the patient? Will he need replacement therapy like insulin?
According to the type of surgery, if the patient will go for a total pancreatectomy, it's usually Whipple procedure. So for sure, he will need to have a replacement therapy. But for isolated lesion, especially in the tail of the pancreas, most of these patients will not need replacement therapy. But in general, patients will with partial pancreatectomy or even with Whipple procedure will need follow-up for the possibility of any local recurrence in the nearby areas.
Okay, clear for us. The other question, does this strong potential towards females to have pancreatic cyst is related to hormonal changes?
I have no good answer for that. There is no mention about that. In fact, and some of types of the tumors have a genetic tendency, in fact, like that type of tumors. But to be related to hormonal factor for females, There is no mention, in fact, and I have no personal opinion in them, but it's not mentioned.
Okay, thank you, Dr. Ahmed. It was a very nice presentation, and thanks for giving us the honor of being with us like every year, and thanks for supporting us.
Shukran.
And now we will have the next presentation by Dr. Riyadh Mikawi about overview of inflammatory bowel disease. Dr. Riyadh is an eminent gastroenterology consultant. He is one of our team in Saudi German Hospital, Riyadh, and we are happy to announce that we will see this presentation with him, overview of inflammatory bowel disease. Thanks, Dr. Riyadh, for joining us.
Thank you, Dr. Ahmed. Thank you, the organizing committee, for giving me this opportunity to present to you. I will try to give a brief about inflammatory bowel disease. I know it's a big topic, so I try to highlight the most important part. So inflammatory bowel disease is composed mainly of two major disorders, ulcerative colitis and Crohn's disease. I'll start with ulcerative colitis, which is a chronic inflammatory condition characterized by relapsing and remitting episode of inflammation, which is limited to mucosal layer of the colon. Crohn's, usually ulcerative colitis, we classify it according to the disease location. If it's include only the rectum or involve only the rectum, we call it proctitis. Rectum and sigmoid colon, we call it proctosigmoiditis. Up to the splenic flexure, we call it left side colitis, and up to the hepatic flexure is extensive colitis. And if it's involved the whole colon, it's called band colitis. And on the other hand, Crohn's disease, usually characterized by transmural inflammation, which involves the whole layer of the mucosa and submucosa, and by skip area of involvement. So area of involvement and area of normal mucosa in between. Most commonly involve the small bowel, mainly the ileum and the proximal colon. However, any part of the gastrointestinal tract can be affected. The more common presentation, as we mentioned, the small bowel involvement, which around 50% of patients, isolated colonic disease only in 20% of patients, and ileocolonic present in like 30% of the patients. The patient journey, usually we have the preclinical inflammation. Usually the patient is asymptomatic and have positive some inflammatory marker. Then the patient develops symptoms of inflammatory bowel disease like abdominal pain, diarrhea, either watery diarrhea in Crohn's and bloody diarrhea in ulcerative colitis. After that, the patient came to us and we diagnosed them with IBD, and the journey was started after that with the medication. We try to induce remission. Some patients, they went to the deep remission and prolonged remission, and some patients, they have a further complication and further disease flare. We classify Crohn's disease and ulcerative colitis. There are too many classifications, but the more common is the Montreal classification. For Crohn's disease, we classified according to the age. We call it A1 if the patient below 16 years, and A2 if the patient between 16 or 17 to 40, and A3 if the patient above 40. And according to the disease location, L1 if the ileal disease, L2 colonic disease, and L3 if it's ileocolonic disease. L4 usually stand for isolated upper GI Crohn's disease. And for the behavior, we have B1, which is non-structuring and non-penetrating disease, which is the most milder one. B2, when patients have structuring disease. B3, when they have penetrating disease, we mean by penetrating if the patient develops fistula. P for perianal disease. On the other hand, the ulcerative colitis, we classified according to the disease extent to E1, which is proctitis, E2 left side ulcerative colitis, and E3 extensive colitis. There is also an Paris classification for ulcerative colitis. They also involve like it's almost similar or identical to Montreal classification, but they have like E4 for band colitis. This is the IBD map. We can see the higher incidence and prevalence of IBD in North America and Europe country. In our area, the Middle East and the Far East, it's considered as an area of low incidence and prevalence of inflammatory bowel disease. In Saudi Arabia, up to mid-90s, we consider an area of without IBD. In 1982, we discovered the first 2 cases were reported. And King Faisal Hospital, there were Hopler and Esbester reported 28 patients with the Crohn's disease and 67 patients with ulcerative colitis between 1976 to 1994. In King Faisal also hospital, there were like 197 Crohn's disease patients and 115 ulcerative colitis patients from 1970 to 2008. In 2003, Al-Ghamdi reported the first study about Crohn's disease. They reported 77 cases from 1983 to 2002 in King Khalid University Hospital. The mean annual incidence of disease over the first 10 years was 0.3 per 100,000 patients and 1.6 per 100,000 patient over the last 10 years. So as we noticed, the incidence were increased and also increased by the last decade. In 2019, there was an IBD information system were developed, which is a website documentation system, including the demographics, disease location and behavior, age at the diagnosis, according to the Montreal classification were mentioned about before, course of the disease and extraintestinal manifestation, complication, surgical and medical therapy. The problem with this registry, it will take time for the patient to have a full data. And in each visit, the data should be updated about the disease location, behavior, and the course of the disease and the therapy. From 2009 to 2018, a full data from King Khalid University Hospital was exported. We found like an 821 patient of Crohn's disease. And some details about them, 32% they had surgery and 45% they are on biological therapy. And 605 patients with ulcerative colitis. 6.4% had surgery, which is total colectomy, and 13.6 patients on biological therapy. As we noticed, the more complications were noticed in patients with Crohn's disease in King Khalid University Hospital. As we can see, the cumulative incidence of IBD is increasing recently as their King Khalid University Hospital studies. We can see here more prominent of Crohn's disease other than ulcerative colitis. Just brief about the burden of the disease. The problem with the disease, it's a chronic disease affecting the young people or young patients. They have a high rate of morbidity, high rate of hospitalization, surgeries, and loss of productivity at work or school in young patients, and their career advancement. About the pathogenesis of the disease itself, there are like many factors. The most important are genetic factors and genetic predisposition. There were many genes was discovered. The most important, we call it NOT2 and CART15, which is important in even prognosis of the disease. Patients who carry these genes have poor prognosis or more active or severe disease. There are many immunological factors, gut microbiota, they play many roles, especially in young and pediatric patients. Environmental, like diet, medication, smoking, infection. But till now, there is no clear explanation and no clear cause of the inflammatory bowel disease. In patients with Crohn's disease, usually, as we mentioned, it's a relapsing and remitting disease. Patient becoming asymptomatic in early on, progressive segmental damage to the gut tract by the time. Only 10% of patients have prolonged remission of symptoms. More than 50% of patients have, more than 50% of patients had structural bowel damage 10 years after diagnosis. Majority of the patients undergone surgery. Excuse me. For ulcerative colitis, the prognosis mainly depend on the disease extent and disease location. For example, patient with proctitis only has a better and good outcome for patient with pancolitis. Usually the patient will have a chronic mucosal scarring, structuring formation after a while, which we call it like lead pipe colon, which is a loss of normal history of the colon. This motility of the colon of the bowel, and anorectal dysfunction. So about disease activity and disease severity. What do we mean by disease activity? Which is a cross-sectional assessment of the patient. We meant by symptoms, sign, and biomarker, endoscopy, and histology. We can ask the patient, how are you today? This is what do we mean by disease activity. So whatever the patient answer, this is represent disease activity. About disease severity, it's a longitudinal and historical factor that provide more complete picture of the prognosis and overall burden of the disease. So how is the disease course since diagnosis? This is represent the disease severity. So when managing patient with IBD and assessing patient with IBD, there is certain patient expectation and there is goals for the gastroenterologist. We have to meet these goals together. So patient expectation, they want to have like symptoms-free, normal quality of life, uninterrupted school or work, normal social and sex life, and anxiety scars or stoma, which is affecting him or his life. Our goals, we are trying to achieve a deep remission, which is endoscopic remission, avoid hospitalization and surgery, prevent complication, minimize bowel damage, and no drug toxicity. Why it's important to join both together? Because as we notice, we have a poor correlation between the patient symptoms and endoscopic findings, especially in patients with the Crohn's disease. We're facing this. Many patients, they are like symptoms free and doing fine, but when we do endoscopy, we found a bad disease. So that's why we need to meet the patient symptoms and the endoscopic remission together. There are several prognostic factors, especially with patients with the Crohn's disease. As we mentioned, for ulcerative colitis, it's mainly depend on the disease location and extent of the disease itself. So for Crohn's disease, we have like many prognostic factors. Those mainly are for the poor prognosis or severe disease, especially if the patient with age of 40, diagnosed before age of 40, they have significant weight loss, more than 5 kg at the diagnosis. Small bowel disease location carries worse prognosis than colonic disease. A patient had both ileocolonic disease also as well. Upper GI Crohn's carries a worse prognosis. Severe endoscopic disease at the diagnosis. Perianal disease at the diagnosis. Presence of a stricture or penetrating, what we mean by fistula. Initial requirement for steroid. Current smoking. Crohn's disease activity index, which is a score for prognosis and disease severity. If more than 200, increased level of CRP, presence of ASCA, which is a serological test. And as we mentioned, the genetic test not to card 15. Initially, our target was to achieve a clinical response. Then we progressed to targeting clinical response, then steroid-free remission, and at the end, we are achieving a mucosal healing by endoscopy. The goal of the therapy modified depend on the availability of the new therapy. We're trying to achieve a deep remission, clinical and biological remission, complete mucosal healing. We're trying to prevent and slowing disease progression. Treatment target. In patients with the Crohn's disease, we defined the clinical response or clinical remission as a resolution of abdominal pain and normalization of the bowel habit. Patient should be assessed in the clinic with a minimum of 3 months from disease activity. Patient goals should be addressed. For endoscopic remission, we defined it by resolution of ulceration and patients should be assessed after 6 to 9 months from starting the therapy. And patient, if endoscopy was reaching to the area or out of reach for the area of disease involvement, like small proximal or distal distal ileum, so we use the imaging study. For the biomarker, it's held, but it's not in the criteria that should be adjusted. For ulcerative colitis, we define the clinical remission by resolution of rectal bleeding and normalization of the bowel habit. As well, it should be assessed after 3 months from the disease activity. For endoscopic remission, we define it by resolution of friability, ulceration, at a flexible or full colonoscopy. What do you mean by MyoScore 0 up to maximum 1, and should be assessed every 3 to 6 months from starting therapy. We're trying to achieve, this is what initially symptoms improvement, then we're trying to reach a clinical remission, steroid-free remission, mucosal healing, and nowadays also we are trying to achieve a histological remission, we call it by deep remission, but still not yet approved as a target therapy. This is the IBD and this is the IBD journey. Usually the patient after diagnosis, here we are diagnosing, we're trying to achieve this curve lower down and to avoid requiring surgery and complication and structure of the disease. This is our target, as we mentioned. So what is an early Crohn's disease? Early Crohn's disease, usually we diagnose in preclinical where patient doesn't have any symptoms. We can find it in the histological by taking biopsies for affecting area or suspected area. Then the early Crohn's disease, which is like 18 months usually before patient developing symptoms, we can discover it either by endoscopy for asymptomatic patient or by imaging study, as this patient had like small bowel involvement with a small bowel enhancement. Usually the patient doesn't have any complication or any symptoms like fistula or abscess or stricture. The role of inflammatory marker like CRP and fecal calprotectin. CRP is not a specific marker for intestinal inflammation. On the other hand, fecal calprotectin considered as a specific marker. In inflammatory bowel disease, CRP has significant associated with the other marker like more specific than other marker like an ESR and thrombocytosis, anemia, and hypoalbuminemia, which is inexpensive and minimally invasive test and quick test. CRP usually we use to monitor an occult internal inflammation. As we mentioned, many patients their symptoms doesn't correlate good with endoscopic findings. So we use a CRP and fecal calprotectin as well to adjust to follow up these patients. So since we started the diagnosis of the first cases of IBD, we diagnosed patient first case of ulcerative colitis in 1870. And the Crohn's disease were diagnosed in 1932. The initial treatment, as we can see, was colectomy for most of the patients. Then sulfasalazine was introduced. Then 1955, steroid. Then immunomodulator with the 6-mercaptopurine and azathioprine was also introduced. And now we have too many medication, biological and small chemical molecules, which is a good medication to achieve a clinical and histological remission. Those are the available biological which got an FDA approval for managing of IBD, and those are the target mechanism of action. We have an adalimumab used for both UC and Crohn's disease, certolizumab, Crohn's disease mainly, golimumab for ulcerative colitis, and infliximab for both ulcerative colitis and Crohn's disease. Or we call it an anti-TNF medication, anti-TNF alpha. Those are the common medication, and usually we consider it as a first-line medication, and it's also good for some extraintestinal manifestation. Natalizumab usually used for MS by neurology, and we stop using it actually for Crohn's disease. We have the more selective anti-integrin medication, which is vedolizumab, which was used for both ulcerative colitis and Crohn's disease. Then we come also to the interleukin IL-12 and 23, like ustekinumab. Then we have the JAK inhibitor, which is tofacitinib, and obatacitinib, which is mainly for ulcerative colitis, and some study and some data for Crohn's disease, but still not yet approved. So what are the limitations of medication for IBD? 66, as we can see, 66% of patients have primary or secondary failure to anti-TNF. Development of antibodies against TNF antagonists. Incidence of primary non-responder in clinical practice from 13% to 30%. Loss of response, which we call it secondary non-responder. So patient, after a while from taking the medication, develop active disease, and patient carries some antibodies and low drug level. So those patients, we call it secondary non-responder. So certain patients, they have to intensification of the dose, and some patients, they require to change the medication or discontinuation of the medication. And subsequently, patient will require surgery. Also, one of the limitations is the adverse effect, risk of malignancy in certain patients, risk of infection, and mode of administration, as certain medication should be given IV and require hospitalization. A new and emerging treatment for IBD, as we mentioned, there is like new medication are used. We call it the small molecule, which is a chemical agent, chemical substance, not other than the anti-TNF and biological therapy. It has some advantage, which is an oral administration, shorter half-life, and less immunogenicity. There is no need to check the drug level and drug antibodies. Certain medication already approved, and certain medication is still under approval. We have the JAK inhibitor, as we mentioned, for tofacitinib and upadacitinib, interleukin IL-12 and 23 inhibitor, like an ustekinumab, and lymphocyte trafficking inhibitor, osmod. I'll just give brief about the biosimilar because now it's commonly used. Biosimilar, we have the biological medication. Usually we refer to biological medication for the medication that require we are getting it from living organisms such as human, bacterial, and yeast. So we're producing these organisms. We have what we call it biosimilar, which is almost similar to those medication, but it's not an identical medication. So it's cheaper, and the study showed it's had the similar effect. So as we mentioned, they are highly similar, but not identical. The benefit, there is no clinical meaningful differences between them. And we can use it as a replacement for the originator biological therapy. The approved medication for infliximab, we have Remsima, which is available nowadays, and Inflectra. Usually it's available in US. For adalimumab, we have the MG-Beta, both for Crohn's and ulcerative colitis. I'll just give brief about the surgery. Is early surgery a way to go? Up to 20% of patients with the Crohn's disease require surgery at the diagnosis. There is no question for timely surgery for complication, like patient has a stricture, bowel obstruction, fistulizing, collection, those patients will require surgery. In limited disease, limited ileal disease, less than 40 centimeter, or ileocecal Crohn's disease in case of 20% or less patient. So those patients, we have an option to go for early surgery, then we'll follow them with the medical therapy. There is a question that are all surgeon and patient willing to face the possible surgical complication or not? So this is one of the limitations to go for medical therapy. Now, what is the problem with an early surgery? What is the early surgery cannot promise? The main desire and hope of the patient affording surgical resection in IBD is to avoid a medical therapy for at least a while. But the problem with up to 80% of patients, especially with the Crohn's disease, after surgery, they develop severe endoscopic recurrence at a 1 year of follow-up. Even considering an endoscopic tailored approach, up to 50% of patients with low-risk recurrence will need immunomodulator or biological therapy. So eventually, we are back to the starting point that most of the patients, they will require again a medical therapy. Only roughly about 50% of patients starting immunomodulator prior or after endoscopic evaluation and is in remission after 1 year. So still we are roaming around using the medication to prevent recurrence. So this is the suggestive algorithm for managing patients with the Crohn's disease. If we have like a poor prognostic factor from the beginning, which we mentioned before, I will try to just mention it quick. A patient age above less than 40 at a diagnosis, small bowel involvement, presence of perianal disease, severe endoscopic lesion at the beginning, extensive anatomic involvement, again, perianal or severe rectal disease, deep ulceration, B2 and B3, as we mentioned, stricture and penetrating disease, prior surgical resection, and patient with smoking. So if patient has 2 or more of these poor prognostic factors, we advise to start from top-down approach, which starting with biological and anti-TNF immunomodulator or other therapy, aggressive. If patient has no or at least one of the poor prognostic factor, we can go step-up approach, which we start with the steroid immunomodulator. If failed, we go up with the biological therapy. The problem with the medication and positioning, how we choose and how we avoid. The problem, we don't have study head-to-head medication trials. Perianal fistula patient will require anti-TNF, infliximab or adalimumab or other therapy. Patient with active extraintestinal manifestation, still we are going with anti-TNF as an option, as the first option. Elderly patient or patient with immunocompromised, usually we consider vedolizumab, which is anti-integrin, and ustekinumab, which considered to be safer than anti-TNF. Patient with personal history of malignancy, anti-TNF, probably okay, but we try to avoid it because there is increased risk of malignancy, though it is a small percent, but patient with history of malignancy, we are trying to avoid it. We consider vedolizumab and ustekinumab, which we consider safer than. There is the risk appear patient, usually we consider if patient has carried the risk of complication or side effect, we consider again ustekinumab or vedolizumab. For conclusion, Crohn's disease and ulcerative colitis are chronic progressive immunomediated disease that profoundly affect patient quality of life. Large gaps still exist in current therapy related to durability, tolerance, and efficacy. Continued progress is being made toward more effective treatment. Biologics and novel small molecule agents such as JAK inhibitor are leading new wave of therapy for IBD. Disease activity or severity important for all patients to know. Remember, 25% of patients in Crohn's disease do not expect CRP elevation. So if CRP is not like very specific markers, certain patients, they have no clinical symptoms, normal CRP, and we found an extensive disease. So endoscopy is needed like 6 to 12 months for most of the patients. Patients should be monitored by using CRP and fecal calprotectin in case of they are doesn't wishing to have endoscopy. Close monitoring and act on the result of monitoring, achieve deep remission, our main target in treatment. Thank you.
Thank you, Dr. Riyadh, for this nice presentation. And we have one question from our Dr. Shiraz. Okay. She's saying, thank you, Dr. Riyadh, for your comprehensive and fruitful presentation. But we know that fecal calprotectin can be positive in other infectious and inflammatory diseases, not only IBD.
Yes.
It can be high in bowel malignancy, celiac disease, Aspergillus, infectious colitis. So can you still consider it specific for IBD?
Yes. It's not considered as a specific for IBD. It's considered as an inflammatory marker. It's useful to follow a patient with inflammatory bowel disease, Crohn's disease, and ulcerative colitis. It's also helped to differentiate between irritable bowel syndrome with the diarrhea. So it's important. It's not used for infectious diarrhea. It's not used to diagnose or to follow up patients with malignancy. So it's helpful to follow up patients with inflammatory, already established diagnosis with inflammatory bowel disease, to know if the patient is in remission or patient with active disease, patient should go undergo surgery. Patient should undergo endoscopy after positive test, but it gives you a clue that patient is in remission or not. A patient with IBS, the area we're facing this more in the clinic. Patient they present with abdominal pain, likely IBS and likely diarrhea. There is no blood. We can use it to rule out or just to make the inflammatory bowel disease less likely in this case.
Does pregnancy increase severity or incidence of IBD?
No, it's the other hand. Malignancy is associated with IBD. Patient with ulcerative colitis, especially if they have like pancolitis, severe disease, they are at risk to have colon cancer. Not on the other hand. Patient with the Crohn's disease, usually with a structure disease, they are at risk to develop malignancy at this point.
Okay, thank you, Dr. Riyadh. That was very nice presentation, and I see many messages in the question and answer board. Just thanking you, not asking a question.
Thank you very much. Thank you for this opportunity. Thank you.
Okay. And now we will have Dr. Mosleh Al-Halafi. He's a consultant in internal medicine and gastroenterology, consultant in neurogastroenterology and gastrointestinal motility. It's a very nice subspecialty in gastroenterology, Dr. Mosleh, right? Okay, Dr. Mosleh will talk today about gastroesophageal reflux disease. Thanks for joining us, Dr. Mosleh.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Saudi German Hospital, for inviting me. Thank you, Dr. Ahmed. Today, I will talk about gastroesophageal reflux disease. My outline, definition, pathophysiology, diagnosis, differential diagnosis, and management. Gastroesophageal reflux disease is a common chronic condition which is characterized by abnormal reflux of gastroduodenal content causing troublesome symptom and or complications. It is estimated to affect up to 20% of the population in the world, which results in a significant reduction in health-related quality of life. GERD can no longer be approached as a single disease, but one with multiple presentations and different diagnostic considerations. Risk factors for GERD include smoking. It is a risk factor for GERD, large meal or eating late at night, consuming food, for example, fatty food or fried foods, going to sleep shortly after having a meal. We should, between meal and bedtime, 3 to 4 hours. Drinking alcohol, coffee, taking medication without consulting doctor, and this medication can be affected in the lower esophageal sphincter. Pathophysiology of gastroesophageal reflux disease, we should know either by poor or weakness of the lower esophageal sphincter. If there is weakness in lower esophageal sphincter, the acid reflux, it will go up to the esophagus. The second pathophysiology is impaired in the esophageal clearance. This means it could be related to motility issues like absence of peristalsis or weak peristalsis in the esophagus. Diagnosis. We should know there is no gold standard for the diagnosis of GERD. The diagnosis is based on a combination of either clinical presentation, response to therapeutic intervention, endoscopic evaluation of esophageal mucosa, and reflux monitoring. Typical symptoms of GERD: heartburn and regurgitation. when you have patient with heartburn and regurgitation, this is typical symptom, and we can consider this is GERD. A typical symptom like chest pain, dysphagia, odonophagia. Other extraesophageal manifestations of GERD, laryngeal and pulmonary symptom, such as a chronic cough, throat clearing, pulmonary fibrosis, laryngitis, pharyngitis. It also has been proposed that GERD might exacerbate asthma, and also it could be cause the ENT problem like otitis media. Classical symptoms are considered, as I mentioned before, diagnostic for GERD. Heartburn and regurgitation is considered for the diagnostic of GERD. Montreal definition of GERD provides rationale for acid suppression therapy without investigation for patients suspected of having GERD. This approach, known as proton pump inhibitor (PPI) trial, is used based on the cardinal symptom, heartburn and or regurgitation, believed to be caused by GERD. Then we can diagnose this by endoscopic evaluation of the esophageal mucosa. We should know before endoscopic what is the indication of gastroscopy in case of GERD. The indication, if the patient has GERD symptom with alarm symptom, like dysphagia, weight loss, bleeding, vomiting, and anemia. What we can see by the endoscopy, we can assess for esophageal mucosa, and we can see some of complication of reflux esophagitis like Barrett's esophagus and Biftecia stenosa. This is the most common complication of reflux esophagitis. Then we can classify the reflux esophagitis based on Los Angeles classification. And the Los Angeles classification of reflux esophagitis is the most widely used and validated scoring system. Los Angeles classification grade A is not sufficient for definitive diagnosis of GERD because it's not really differentiated from normal. In this slide, we can see the endoscopic pictures of GERD. As I mentioned, we have reflux esophagitis based on Los Angeles classification. We have Los Angeles classification A. In A, the mucosa, we have only break in one or more mucosa less than 5 millimeters and not extend between two folds. Grade B is break in more than 5 millimeters in one or two fold without extend between two mucosal folds. Grade C is more than 5 millimeter break and extended between fold, but less than 75% of esophageal circumference. Grade D, more than 75. And in case of we see grade C or grade D in endoscopy, we should repeat scope after 6 to 8 weeks after treatment to reassessment the mucosa of distal esophagus to rule out complication like Barrett. Physiological test for the diagnosis of GERD, we have esophageal manometry and reflux monitor. Esophageal manometry, high resolution manometry, can be used to assess motility abnormalities associated with GERD, but it's not alone a diagnostic test, and no manometric abnormality is specific for GERD. Reflux monitor either by Bravo capsule or transnasal catheter-based testing. What is the several factors are assessed during reflux testing? Include acid exposure time, number of reflux events, symptom correlation. Impedance pH testing also allow for measure of the weakly acidic or non-acid reflux, assessment of bolus clearance, and extent of proximal reflux. In this slide, we can see, as I mentioned, the manometry, high resolution manometry. High resolution manometry is a probe inserted transnasal to distal esophagus to measure the lower esophageal sphincter pressure and to assessment of the esophageal peristalsis and to see if there is weak peristalsis or absent peristalsis. Also on this slide, you can see here the reflux monitor, either by Bravo capsule. You can see here Bravo capsule is placed by gastroscopy in the distal esophagus 6 centimeters above the edge junction. And the other modality is the pH study, transnasal pH study. This is catheter inserted in the distal esophagus and measure the pH for 24 hours. Differential diagnosis of GERD, rumination syndrome, achalasia, eosinophilic esophagitis, reflux hypersensitivity, functional disease, cardiac or pulmonary disease, gastroparesis. Management of GERD. Management of GERD require multifaceted approach. Diet and lifestyle change, medication, pharmacological therapy, surgical anti-reflux surgery, and endoscopic management of gastroesophageal reflux disease. The diet and lifestyle change. Common recommendation include weight loss for overweight patients, elevating the head of the bed, stop smoking and alcohol, avoid of late night meal and bedtime snack, staying upright during and after meal. The pharmacological therapy include PPI therapy. Proton pump inhibitors can tend only to proton pump that are actively secreting acid, are the most common prescribed medication, and demonstrating consistently superior heart pain and regurgitation relief, as well as improved healing of reflux esophagitis. Because meal stimulate proton pump activity, PPI control intragastric pH best when given before a meal, 30 or 60 minutes before breakfast, for once daily dosing, and 30-60 minutes before breakfast and dinner for twice daily dosing. Bedtime dosing is discouraged because this is less effective than pre-dinner dose in acid control. The other medication, Dexelan, is dexlansoprazole, is a dual delayed release PPI in which first absorption in the duodenum, then partially further down the small bowel, seem to have similar efficacy in pH control regardless of the meal time. There seems to be wide variation in individual intragastric pH control between PPI, a rationale for considering switching PPI in patients with incomplete response. Studies suggest that genetic differences in CYP-C19 metabolism affect PPI response. What about long-term PPI using? PPI are the most effective medical treatment for GERD. some medical studies have identified an association between the long-term use of PBI and the development of adverse conditions like intestinal infection, pneumonia, stomach cancer, osteoporosis-related bone fracture, chronic kidney disease, deficiencies of certain vitamins, heart attack, stroke, dementia, and early death. Those studies are not considered definitive and don't establish cause and effect relationship between PBI and the adverse condition. High quality studies have found that PBI do not significantly increase the risk of any of these conditions except intestinal infection, and it's safe medication. Other group of medication, histamine, H2 receptor antagonist. The addition of bedtime H2 receptor antagonist has been suggested for patients on PBI with persistent nocturnal symptom. A well-performed study demonstrates loss of pH control after a month of bedtime H2 receptor antagonist therapy. The other medication, prokinetic, baclofen, and sacralfate. In this slide, this summarizes the diagnosis and management of GERD. If we have patients presented with heartburn and or regurgitation without alarm symptom, and symptoms with sufficient frequency and intensity to impair quality of life, we can trial the first 8 weeks once before meal daily PBI trial. If there is complete relief, this means GERD likely, and we can discontinue PBI. If the symptom recurrent or there is no incomplete relief after 8 weeks, we can consider gastroscopy of PBI 2 to 4 weeks. If the gastroscopy showed LA grade, P, C, or D, or other complication like pellet more than centimeter, this means this is GERD confirmed. But if LA Los Angeles grade A, this is not confirmed GERD. If the gastroscope is normal or the LA classification grade A, we can proceed with the reflux monitor of therapy, either by Bravo capsule or transnasal pH study. If abnormal, this is GERD confirmed. If normal, we can consider other causes of symptoms. Extraesophageal GERD symptom. If we have patient present with extraesophageal symptom like laryngitis, pulmonary fibrosis, as I mentioned before, we should take detailed medical history to identify the other potential causes, refer to other specialty for evaluation. If the history suggests non-GERD cause is likely, you can refer to ENT or pulmonology. If there is typical GERD symptom, heartburn and regurgitation, and extraesophageal symptom, we trial PBI, PID up to 12 weeks. If improved, this means we treat as GERD. If no improvement, we should proceed with the reflux monitor. If extraesophageal symptom only without typical GERD, or the extraesophageal symptom not improve after 12 weeks, we proceed with reflux monitor, either by, as I mentioned, pH study, transnasal, or Bravo capsule. If abnormal, this we treat as GERD. If normal, we consider pH impedance monitor. Anti-reflux surgery for treatment of GERD. We have laparoscopic fundoplication or anti-reflux surgery is effective in patients with typical GERD symptom with acidic or non-acidic reflux. might be considered as treatment option in patients with refractory GERD with ongoing acid or non-acid reflux, but should be avoided in case of esophageal hypersensitivity and functional heartburn. The other anti-reflux surgery is magnetic sphincter augmentation, and this is like it's gastric band placed by surgical colleague around the lower esophageal sphincter to control the lower esophageal sphincter pressure. Endoscopic management of gastroesophageal reflux disease, radiofrequency application, the Strita, and I think it's no more used at this time. The other one new modality is endoscopic fundoplication, either by TIF or by Gerdex. Refractory GERD is persistence of typical symptom, heartburn, regurgitation, that do not respond to standard double dose of PPI for treatment period of at least 12 weeks. One of the most important factors that contribute to refractory GERD is poor drug compliance and improper dosing. The cause of refractory GERD can be classified as reflux-related and non-reflux-related. Reflux-related include drug compliance, residual acid reflux, weakly and non-acidic reflux, esophageal hypersensitivity, nocturnal acid breakthrough, duodenogastric reflux, PPI metabolism, non-reflux related functional chest pain, functional heart pain, esophageal motility disorder like achalasia, scleroderma. Achalasia, we can diagnose this by the gold standard for achalasia diagnosis is high resolution manometry. And scleroderma, we can diagnose also by manometry, and we can see absent peristalsis and weak lower esophageal sphincter in manometry. Eosinophilic esophagitis, impaired gastric empty, extraesophageal symptom, chronic cough, asthma. If we have patient with refractory GERD symptom, we should evaluate PPI and compliance. If the compliance and the dose is adequate, we proceed to pH monitor off or on PPI. Versus acid reflux, we can give the patient long-acting PPI, alginate, add on the PPI, anti-reflux surgery or endotherapy. If the pH showed non-acidic reflux, add prokinetic baclofen or anti-reflux surgery and endotherapy. If the pH monitor showed esophageal hypersensitivity and functional heartburn, this means there is no indication at this time for anti-reflux surgery or endotherapy. We can add PPI and tricyclic antidepressant. If the evaluation at the first time there is non-compliance or PPI, it's not adequate, we can optimize therapy. Take-home message. The most common causes of GERD are a weak lower esophageal sphincter and increased frequency of transit lower esophageal sphincter relaxation. And we can diagnose this by manometry. There is no gold standard for the diagnosis of GERD. Classical symptom, heartburn and regurgitation are considered diagnostic for GERD. Indication for endoscopy in patients with GERD is, as I mentioned before, alarm symptom, dysphagia, bleeding, weight loss. Most important factor that contribute to refractory GERD is poor drug compliance and improper dosing. Thank you so much.
Thanks, Dr. Mosbeh. Still with him, here some questions. One. question from Dr. Abdul Hamid. What about the safety of long-term usage of BBI and gear? Is there any side effects in long-term usage of BBI?
As I mentioned before, it's in general is a safe medication, and there is a high study, as I said before, found that BBI do not significantly increase the risk of any of these conditions, as I mentioned before, except intestinal infections.
Another question from Dr. Gamal. Is the gear related to H. pylori infection or can it be caused by H. pylori?
Yeah, if the patient has H. pylori or gastroparesis, it can increase the reflux symptom.
Dr. Ibrahim asking if there is any correlation between using of BBI and hypercholesterolemia or
regarding this as a side effect, there is no side effect, as I know, to increase the cholesterol in the body from BBI.
Okay. Many thanks for you about this lecture. Thank you.
Thank you.
Thank you. Now will be proceed for next lecture with our Dr. Ahmed Abdulli. Nice to see you, Dr. Ahmed.
Assalamu alaikum.
Dr. Ahmed is a consultant gastroenterology. Dr. Ahmed is working in advanced endoscopy with very long data in Kingdom since around more than 71 years. Dr. Ahmed worked already in many high specialized hospitals in Kingdom. Dr. Ahmed will give us today a lecture about endoscopic diagnosis and management of non-variceal upper gastrointestinal hemorrhage. Welcome, Dr. Ahmed.
My slides, it's
Dr.
already
Ahmed, you can unmute your mic, please. No sound, Dr. Ahmed.
Now there is sound. And now it's already open.
Dr. Ahmed,
Aywa.
in left side of the screen down.
Yes,
there is
it's
a
open.
mute icon. You can make it mute instead of unmute.
Now you can hear me.
You can increase the volume, sound volume, Dr. Ahmed.
It's a maximum. Now you can hear.
Still no sound.
It's a maximum.
Dr. Ahmed.
Hello. Hello.
Yes, Dr. Ahmed, clear now. You can start.
Okay. Only my slides because I put it. Yes, now.
You can share your screen, Dr. Ahmed, please.
Okay. Now it's okay? You have the
Yes.
slide?
Yes, yes.
Thank you for Dr. Ahmed and for the Saudi German Hospital and Academic Affair for inviting me to present this topic. The upper GI bleeding non-variceal, the goal of medication therapy in upper gastrointestinal bleeding is to correct the shock and coagulation abnormality and to stabilize the patient, so that further evaluation and treatment can be proceed. In addition to intravenous fluid, patient may need transfusion of back-artery disease, and high dose of proton pump inhibitor may reduce the need of endoscopic therapy. Why can't I make it? Hello?
Yes, Dr. Ahmed.
Yes.
Dr. Ahmed.
There is many definition for acute GI bleeding, and from this definition, overt bleeding may show up as vomiting blood or black tarry stool. The vomiting blood, which is may be to red, to might be dark brown and resemble to coffee ground in texture, but the black tarry stool or rectal bleeding usually in or with stool. With occult bleeding can lead to dizziness, difficulty to breathing, fitting, chest pain, and abdominal pain. The cause of acute bleeding, the most common cause of acute upper gastrointestinal hemorrhage are non-variceal. These include gastric and duodenal peptic ulcer, mucosal erosive disease of the esophagus, stomach, and the duodenum, and also malignancy. Also, Mallory-Weiss syndrome, a duodenal lesion, or other diagnoses or no identified cause possible, which lead to obscure bleeding and need more investigation. The cause of acute bleeding, by definition, regarding the timing of upper gastrointestinal endoscopy in acute bleeding relative to the time of patient presentation. If this is less than 12 hours, is it urgent? If this is more than 24 hours, it's early, and if this is delayed, is more than 24 hours. The symptom of shock in bleeding, if the bleeding start suddenly and progress rapidly, it can lead to shock. A sign of and symptom of shock is included drop of blood pressure, no urine or small amount and frequent, rapid pulse and unconsciousness. The cause of non-variceal GI bleeding is peptic ulcer. This is the most common cause of upper GI bleeding. Peptic ulcer in the stomach can be in the stomach and upper portion of the small intestine. Stomach acid, either bacterial or use of anti-inflammatory drug, damage the lining of and leading to formation of ulcer. The classification of Forrest can identify the ulcer and categorize this ulcer for the modality of treatment of this ulcer. Also, tear in the esophagus, which is known as Mallory-Weiss tear, they can cause a lot of bleeding. These are most common in people who drink alcohol to excess. Also, esophagitis, this inflammation of the esophagus is most commonly used caused by gastroesophageal reflux disease. The complication of non-varicose GI bleeding, it can be a shock or anemia or death. The prevention of non-varicose upper GI bleeding to help prevent of GI bleeding, limit the use of non-steroidal anti-inflammatory drug, limit the use of alcohol, stop or quit of smoking, and in gastroesophageal reflux, we should follow the instruction of treatment. The diagnosis, very good medical history, including a history of previous bleeding, conduct a physical exam, and possible order test. Test may be include blood test or stool test, blood test for complete blood account, a test of blood clot, and a platelet account, and liver function test. And the stool test can be held to determine the cause of occult bleeding. Nasogastric lavage is a tube passed through the nose into the stomach to remove the stomach content. This may help to determine the score of the bleed. But really, this method, it's a question mark actually in many centers, which is more specialized to treatment for GI bleeding, and the patient, we are not using nasogastric lavage. We shifted the patient directly when we need for gastroscopy. And diagnostic endoscopy, by upper endoscopy, this is a procedure, the procedure to use to examine the upper gastrointestinal tract. The capsule endoscopy also can be used in the procedure for the small bowel bleeding. This is a small capsule, looks like a vitamin size capsule, can be swallowed, and there is thousands of imaging registered through the wire which is around the waist, and can be recorded and explore the small intestine. Angiography, a contrast dye is injected into the artery, and series of X-ray are taken to look for treat bleeding vessels or other abnormality. Imaging test, a variety of other imaging tests such as an abdominal CT scan may be caused to find the source of bleeding. If the GI bleeding is severe and non-invasive, test cannot find the source of which lead to surgery, so that can explore the anterior small intestine. Fortunately, this situation is very rare. The treatment for GI bleeding, before treatment to start, we need pre-endoscopic management. The pre-endoscopic management for upper gastrointestinal bleeding are at risk of hemodynamic shock. The priority into the assess the adequacy of the airway, the circulation, and the intravenous access should be secured with a large bore cannula, pulse oximeter, cardiac activity, and automated blood pressure measurement should also be monitored. Also, we should identify any use of non-steroidal anti-inflammatory, anticoagulant such as warfarin and anti-platelet medication, since this treatment can cause or exacerbation of GI bleeding. Pre-assessment also, management for endoscopy, we need coagulation time, and the hemoglobin level should be checked as well, and blood type, cross-matching for any appropriate number of units of red blood cells if necessary. Recognize the serious comorbidity condition may require hospitalization regardless the severity of their bleeding. A scoring system can help to categorize a patient with upper GI bleeding if this is low or high risk of rebleeding and mortality. The most widely applied scoring system are the Rockel and the Blatchford score. Pre-endoscopic management also early we need early endoscopy can decrease the length of patient hospital stay, but no additional benefit of urgent endoscopy within 1 to 12 hours of presentation. And there is a strategy we can use it for pre-endoscopic management and endoscopy procedure. This is the if there is hematemesis and tarry stool or coffee ground like emesis, we should to initiate the assessment of resuscitation, pre-endoscopic management, and airway volume replacement of blood transfusion, medication history, and coagulopathy. And when we perform the endoscopy in urgent or elective, we should to stratify. If there is no source of founded by endoscopy, we can consider colonoscopy and small bowel endoscopy to enhance the enhance abdominal CT for evaluate the patient. And if the endoscopy not find the bleeding and the patient in low risk of bleeding, we should to discontinue the relevant medicine, and we can start medication of PPI, and we should consider the eradication of Helicobacter. But when we have the endoscopy and active bleeding or high risk of patient to bleeding, endoscopy with hematemesis, if we stop the hematemesis with the endoscopy and the procedure, we should lead to discontinue relevant medicine and to start the PPI and consider Helicobacter pylori eradication. But if the endoscopy not stop the bleeding, we should to lead the patient to interventional radiology or surgery. After endoscopy evaluation and assessment by the full Rockel scoring system is recommended because endoscopic finding, including adherent clot or visible vessels, can be combined with a clinical factor to predict a patient risk of rebleeding and mortality. Blatchford score is used to identify low-risk patients who do not require endoscopy intervention also. Early endoscopy within 24 hours of presentation is recommended for most patients with acute upper GI bleeding. There is different modality to use and device use it by endoscopy, and each unit of endoscopy perhaps need this device to treat GI bleeding. There is the most common, we use the hemoclip system, and there is a different device and different size, and some of them different model to rotated and not rotated. Also, we can use the Cotary device, which is argon plasma coagulation, is a non-contact thermal method whereby ionizing the argon gas deliver monopolar electric current that efficacy coagulate the tissue. And this machine is needed in each unit of endoscopy. And in case we have no argon plasma coagulation, I think at least we should to provide for the unit the electric hot biopsy forceps, which we can use it for coagulate after injection the blood vessels who bleed. The injection device, the epinephrine injection, is a common and effective method of achieving endoscopic hemostasis owing to its low risk and low cost and simplicity. And epinephrine injection alone is superior to medication management alone, but is inferior to all other methods and should no longer be employed as a sole endoscopic treatment when other options are available. There is also many material, not only adrenaline can be injected, but we should to keep it in mind when we inject adrenaline, it may cause severe hypotension during emergency gastroscopy. The most common used injector have a diameter from of 23 or 25 giga, while the needle length it should be 3 to 5 millimeter, and many needles especially can be adjusted. The length from 2 to 7 millimeter can be available. Hemospray, this is a device from a company which can be used in case we are use or abuse our device and the bleeding is still oozing. In top of this, we can use as a hemospray to stop completely the bleeding. Supporting apparatus needed in each unit of endoscopy: water jet equipment endoscopy, carbon dioxide insufflation, cup applicator, and multi-bending scope, which can decrease the limitation of endoscopy management. 10 to 30% of patients with non-varicose upper GI bleeding have repeated bleeding. Patients in whom hematemesis is not achieved with the endoscopy require transarterial embolization or surgery. And I should thank everybody to hear me about this, because I emphasize only this issue for this lecture for internal medicine, not for advanced gastroenterology people. Thank you very much.
السلام عليكم.
Any question?
Dr. Ahmed, you can hear me?
Yes.
Okay, very good. Let's check if we have some questions. No questions. Okay, thank you, Dr. Fali. We have a very nice presentation with you.
Thank you.
Till now, I didn't have any other question for you. Thanks, and this was your first time with us, and inshallah it will not be the last time, and hope we have you every year, inshallah.
Thank you very much. Thank you. And thank you for the audience and for Saudi German Hospital to invited me.
It is our pleasure, and thanks for giving us the honor to hear from you. And we have more than 1,000 participants now and attendants who enjoy and have the privilege to hear from an expert endoscopist like you. Thank you.
Thank you for all you.
Dr. Afif. And now we will have a break for 5 minutes, and our Professor Dr. Afaf, endocrinology consultant in King Abdulaziz Medical City, National Guard, and also she's the president of Saudi Society of Endocrinology and Metabolism. Within 1 or 2 minutes, she will join us now.
حضرتك وممكن حضرتك تبدأ على طول.
معلش ممكن ارفع لي بس يعمل
لا هو ستوب شيرنج. سعداء بوريتي.
Do you hear me?
Yes, we are on the Zoom right now.
Okay, so it's
We can
clear.
hear you.
So,
Okay.
do you hear me now?
Yes.
I
Everything
cannot
is
hear you.
clear. Yes, please share the screen.
Wait. I cannot hear you.
It is from your laptop. F3. You can use F3 to raise the volume.
Sorry, I cannot hear you at the beginning, but can we just share the slides? Share screen, okay?
Yes. Okay.
So I will go with the, yeah.
We are lucky to have Dr. Afaf El-Shammari with us. She's consultant and head of the division of endocrinology in King Abdulaziz Medical City and the president of Saudi Society for Endocrinology and Metabolism. Thanks, Dr. Afaf, for being with us. And our presentation now is about dyslipidemia in diabetes.
Okay, thank you very much. I hope you hear me well. Just stop. Okay. So we'll start. Thank you very much for inviting me for this very prestigious meeting, which is running on a yearly basis, as far as I know, and I was part of it a while ago. Today is the presentation about the dyslipidemia and diabetes. First thing, why it's not. First thing is the introductions, is the diabetes dyslipidemia, is the cluster of lipoprotein abnormalities characterized by increase in triglycerides level, decreased HDL, and increase in small dense LDL. It's extremely common in type 2 diabetes, affecting around 70% of patients. The cardiovascular disease is the major cause of morbidity and mortality in both men and women with diabetes, approximately around 50 to 70% of them. The risk is more in women, which is a 3 to 4 compared to the men with 2 folds. The diabetes is equivalent risk factor as a history of previous cardiovascular event. The duration of diabetes and the presence of other risk factors likely determine whether the patient with diabetes has a risk equivalent to patients with a history of a previous cardiovascular disease. Numerous of the studies have shown that patients with diabetes who have cardiovascular are at very high risk of having another event. What about type 1? Is the type 1 is as type 2 with the risk of diabetes, but the duration is more. Women with type 1 is having twice excess of risk of fatal and non-fatal vascular event compared to the men with type 1. Around 50% of patients with type 1 are obese, and they are having metabolic problems, and this will subject them at the risk of developing of the complications. Here we can see from the graph, just see the blue color at the top of the screen. The blue one, those patients, they are not diabetic and without any prior MI. You can see here over the x-axis is the year, and with the survival in the y-axis. So you can see is the patient with no diabetes over 8 years, what is their survival rate. But if we compare it to the orange color, which is those are diabetic, okay, and they don't have any prior MI, and the risk of, or the survival rate is less with diabetic if we compare it to the subject who doesn't have diabetes. What about if they're having prior MI? So the patient with the green is a patient, they don't have diabetes, but they are having prior MI. And the patient with red color are diabetic with the prior MI. And you can see the survival. It's very, very clear that is the really survival is much, much less in diabetic patient with a prior MI compared to the patients with the MI or cardiovascular, but they don't have diabetes. This is showing us the mortality and morbidity from coronary artery disease if the patient they are diabetic compared to non-diabetic. Let's go just over quickly the pathophysiology. What happened with the LDL? Why we're having the problem with the cholesterol issues or dyslipidemia in diabetics? It's just on the left side. You can see the fat cells. Is the fat cells with releasing free fatty acids is controlled by the insulin level. So the insulin is not only controlling the blood sugar and controlling the free fatty acid release as well. So if we have a problem with the quantity or the quality, the insulin resistance, this will make the fat cells will be less controlled by the insulin, and this will release more free fatty acids. Free fatty acids will go to the liver, and then through the liver is the VLDL, and this is the setup. Will take the VLDL converted to the LDL. It's not only this, it will take it again, so the circle will go around and around, taking the very low density lipoprotein and going with the LDL, and this is the pathognomic LDL, and this will cause the more problem and increasing the LDL in diabetics. Here, the endothelium showed in diabetic patients if this is normal, and if there is a problem with atherosclerosis, you can see it have formed and blocking the cardiovascular or blocking the vessels. And here the effect is accelerated by the diabetes, hyperglycemia, insulin resistance, inflammation, and diabetic dyslipidemia as well. Here is the most famous graph that we get it from the Heart Association that was almost 2 decades before, that showing the LDL correlation, the LDL and the association with the risk of the cardiovascular disease. You can see with the x-axis is the LDL, if it's low, and this is the relative risk of developing cardiovascular. Not only the LDL is the correlation with the HDL. So if the HDL is high, which is the protective, and the LDL is low, which is the bad cholesterol, you can see this is 85 and 100. The one left on the one on the left corner, the light pink, is this is the risk is very low. While on the right corner, the big one, the dark or the burgundy color, dark red, is when the HDL is low at 25 and the LDL is high, more than 220, this is the risk will be very high. So this is not only the LDL, HDL as well. So both of them, this is proven the cardiovascular risk will increase with the high LDL and with low HDL as well. What we're gonna do, the modifications for the level, is it the diet, the exercise, and how's being effective? Or the carbohydrate is actually the most is effective on the weight reductions. Carbohydrate, physical activity is reduction in triglycerides, mainly around 10%. You can see it is the carbohydrate is around 10% triglycerides, and weight reductions around 10% triglycerides, and physical activity around 10% reduction. While is the physical activity is for the HDL will decrease the HDL around 5%. So when a patient is they're way above the target and coming to the clinic, advising them for the diet, we're not expecting to be controlled. Just consider around 5%. With the LDL reductions if we have the LDL high. The HDL will be increased with the physical activity, not with the weight reduction. It's actually is being reduced by weight reductions, but not with the carbohydrates. Is the carbohydrate actually reducing the HDL? So weight reduction, physical activity, will help us more with low triglycerides, 10%. With the reductions of the LDL around 5%, with increment of the HDL. What about the glucose lowering medications on lipid level? Is it effective or not? As we know from the metformin, can have decrease in triglycerides and HDL. This is very modest effect. Sulfonylurea has no effect. While DDP4 inhibitor, GLP-1, acarbose, And the big liposomes or TZD group will decrease postprandial triglyceridemia, but this is very small. What about the SGLT inhibitor? This will have little increase or small increase in LDL, but has no effect on triglycerides, and the insulin has no effect. Okay, now we go with the studies that been published for more than 20 years regarding the use of medications, and basically with the statin, with the primary prevention that patient does not have cardiovascular, or secondary prevention. Is it effective or not effective? Is lipid lowering is being good and decreasing the events or not? The thing is, and the diabetes, like when they start with their studies like 20 years ago, the diabetes was not the target, but it's part of the population being selected in these studies. Except like carbs in the total population that been used on the left side of primary prevention, carbs is all diabetic. But when you look like for the HBS, around 1/3 of population, they are having subgroup analysis, they are diabetic, and the total, they are not diabetic. And they're using statins group, whether atorvastatin, simvastatin, and the bravastatin showed is effective in reducing the cardiovascular risk as a primary prevention. While in the secondary prevention, we can see like if the 4S, which is very famous with the simvastatin, is reducing the secondary preventions, or the reducing the reaching the target with secondary prevention with the cardiovascular events. But you can see the total studies around 4,444 patients is around like 200 plus patients with they are diabetics. If you can see with the lipid study, the bravastatin, using bravastatin 40%, is the total is around 9,000, while around 1,000 are diabetic. So it's gone, but still they are part of the sub group analysis. So the statin, with all the studies that I showed just the previous slide, it showed solid evidence for the long-term efficacy and safety for the statins to reduce cardiovascular event, whether primary or secondary. There is no doubt, no one in the medical field questioning the efficacy of the statins. Maybe we're questioning the adverse effect, the indications when we start the patients. These are the things is important, but the efficacy is very solid. Here, the statin therapy is here reducing cardiovascular. You can see collecting the whole studies with their non-diabetic and diabetic. The red color is diabetic patients. You can see with the 4S, there's reductions on secondary prevention. And primary prevention, there is showed in cards is really reductions with diabetics and with non-diabetics as well. The light blue is the combination whether diabetic or non-diabetic, but still is the whether secondary or primary preventions is shown reducing the cardiovascular event. Here, the meta-analysis with the cardiovascular event reduced by statins, you can see here on the y-axis is reductions of the cardiovascular event per year, and with the reductions, the x-axis is reductions of the LDL. So the lower the LDL, you can see the arrow is the lower the LDL, the better outcome. So reductions of cardiovascular mortality by 20%, and with the total mortality 10%, and around 170,000 patients been enrolled in randomized controlled trial. So this is over 27 randomized controlled trial, and all of them showing the lower LDL, the better outcome. What about the options? So we don't, as I mentioned, we don't have a doubt reducing statins, but what about the options if the LDL has to be used with high-risk patients, but we're not reaching the target, which is less than 50% reductions of the total, or LDL 70, or patient cannot tolerate statins? Do we have an options? What we're gonna do? So we have non-statin options for the LDL. We have bile acid sequestrants like cholestyramine. We have nicotinic acid niacin. We have cholesterol absorption inhibitors, istamir. we have PCSK9 now, is eviculumab or eliquimab can be used. We have the other novel drug is the citrate lylase inhibitor and others. The one it showed is really reductions in atherosclerosis cardiovascular disease when combination with a statin is azacitidine and has an effect on this and reducing the LDL level. So here we have the monotherapy for the studies that with the other non-statins like gemfibrozole, fenofibrate, and most of them did not show statistically significant in reducing cardiovascular events. What about PCSK9 is actually when to use it, is these are the studies. First of all, we would like to know, is this an effective in changing LDL over time or no? So we have two studies, major study, Fourier, which is around 27,000 patients, and with Odyssey is 18,000. The Fourier, they used PCSK9, which is the eviculumab compared to the placebo, and showed reductions around 59% in the LDL when used. And the Odyssey outcome, changing in the LDL over 2 years, they enroll around 18,000 patients, almost 19,000 patients, compared to the placebo, with the eliquimab showed reductions in 61%. So it's really effective. But one thing is no indications to be used as a primary. So statins, if not statin, azacitidine, and then PCSK9, because it's been used as injections and because maybe of the price. So still it's been add on rather than to start with. What about the cardiovascular outcome if we use PCSK9? Is it effective as statins? We know is now is reducing LDL. Is here Fourier with eviculumab or Odyssey outcome? Is the Fourier used the MACE, cardiovascular death, myocardial infarction, stroke, hospitalization for unstable angina, or coronary revascularization? With Odyssey outcome, it for MACE, coronary heart disease death, non-fatal MI, ischemic stroke, or unstable angina requiring hospitalization. For both of them, showed an significant reductions on the MACE. The other one, which is inclisiran, it's the sRNA approach to inhibit PCSK9. It's the studies enrolled around 1,500 patients with atherosclerosis cardiovascular disease. The mean age is 66, and the baseline LDL is around 105 milligram per deciliter, and they're on a statin. And they use 285 milligram subcutaneous versus placebo. They use it as 0, 90 minutes, and then Q1 80 days, so twice a year. And they compared with LDL cholesterol, and the Orion is 10 trial and showed significant reductions of the LDL over time. So it's confirming that reducing the LDL. What about the other one for options for the LDL? So we know the statins, we know the SMF, we know PCSK9. Now, bempedoic acid is the ATP citrate lyase inhibitor, can be used for the LDL. So what is the mechanism for this? Just to go quickly, the HMG, which is the statin, is going to reduce the enzymes or stop the enzymes here, the blockage, and this is eventually to affect the pathway of the LDL, and this will subsequently will reduce the LDL. What happened with bempedoic acid is actually going with the straight, so it's like 2 steps before the statin reductions. So this is how does it work to reduce the LDL. So is the bempedoic acid, is there an effect with the study over 12 weeks? It showed here whether the patient is having high cholesterol despite maximum tolerated statins, or on the right side is they are unable to tolerate statins. Is actually both of them showed reductions on the LDL. But one thing is we have to be cautious about the adverse effect, which is mainly the hypoglycemia and mild reduction GFR, mild increment on the hepatic enzymes. The other thing is the bempedoic acid on add-on estimate compared to placebo or in statins intolerant subjects. So if you add on, can we have effect on the LDL? Is actually here when we compare it with those with the dark black is are using bempedoic acid add on the estimate and showed reductions compared to the patient on placebo. So there is really an evidence with the triglycerides on the LDL. So this is really effective in reducing the LDL and triglyceride as well. Okay, so if we reduce LDL, can we assure patients or making sure that the achieving the LDL goal is the reducing 100% of the cardiovascular events? Is actually there is 30 to 40% recurrent cardiovascular event in statin estimate treated patients. Okay, so they are using the medications, but still developing the cardiovascular. So the basic reasons why. The first question, are we reaching our goal? Is the LDL target is achieving the goal exactly with the target? Or is there any other factors like triglycerides rich lipoprotein or lipoproteins or some other factors? So the triglycerides, we have to look for secondary causes, the obesity, the alcohol, hyperglycemia, especially the blood sugar is not controlled. So we have to start controlling blood sugar, comorbidities like hypothyroid, CKDs, or other comorbidities, drugs like corticosteroid, estrogen. So we have to think about NCD psychosis to exclude other secondary causes controlling triglycerides. Okay, the current agent for triglyceride management. So what is it? According to the most crucial one is before the medications is the diet and exercise achieved in reducing the triglycerides. Okay. The other thing, medications fibrate. We can use the fibrate, fenofibrate, gemfibrozole, nicotinic acid, and omega-3 acids, and especially EPA, which is the icosapent ethyl. This is from the omega-3, showed effectiveness in decreasing the triglycerides. Okay. Other new agent in development or trials like bimafibrate. This will decrease the triglyceride, but still the trial is in progress. The things is as I mentioned here, the omega-3, which is ABA, is it effective or not in interventional trials, is here. When we have it with the secondary endpoint, primary, the endpoint here is reducing the cardiovascular death, myocardial, stroke, and cardiovascular, and stable angina. And with the secondary endpoints, cardiovascular death, and it showed reductions when we use the EPA, which is the omega-3. But we have to be cautious with some of the adverse effects, like bleeding disorders and the atrial fibrillation when we use it with high doses. Okay, now is they claim the mechanism reducing cardiovascular, that ABA, which is the omega-3, is lowering because lowering triglyceride rich lipoprotein is anti-thrombotic effect, anti-inflammatory effect. So these anti-arrhythmic actions could help in reducing the cardiovascular events. Other aspect is triglycerides. How to approach, I will go over it quickly for the sake of the time, is when triglycerides is elevated, which is less than 500, okay, we have to look for secondary causes, controlling blood sugar, medications, other comorbidities. If the triglycerides more than 500, most likely it's a primary. So what we're going to do, we have to decrease it, because if the triglycerides more than 1,000, the risk of pancreatitis will be high. So we have to have intensifying lifestyle measures, as I mentioned earlier, reduce the fat intake to less than 20%, and fibrate, fenofibrate, and omega-3 can be used. Niacin plus minus, we can use it if we're not reaching the target. If it is less than 500, with the cardiovascular, we have to look for cardiovascular and diabetes another 2 risk factors. If those are there, we have to use statins because achieving LDL goal and hoping to give the omega-3 around 4 grams per day, which is not, as we heard from the patients, they are using 1 tablet a day if they want to treat triglycerides. So it's around 4 grams, okay? But if the patient doesn't have risk factor, we use the statin as primary prevention if the LDL is high. So how's the effect of the medications there? Statins is mainly reducing the LDL 20 to 60%. And with the triglycerides, have some effect is around 35%. With the fibrate, we can see 20 to 50% reduction triglycerides, but very little on LDL. Ezetimibe is around 15 to 25% reductions. That's why when we add it to the statins, hoping to have more reductions. And is ezetimibe having effect on triglycerides? Just 10 to 20%. What about PCSK9? It's around 50 to 60% reduction of the LDL. So this is almost competing with the statins, and with the triglycerides is very little, 5 to 20%. And the limidic acid is around 25%, is equal to ezetimibe and the LDL, and has no change on triglycerides. High dose fish oil, this will increase. This is important. Okay, so the patient with high LDL, with high triglycerides, will reduce the triglyceride 20 to 50%, but might increase the LDL, which is around 0 to 50%. So we have to be cautious when we use it with the patient with the triglycerides. Now, what is the optimal LDL goal? What we're supposed to, if we treat a patient, we have to go with the guidelines. Are we reaching our target or not? With the European associations, European Society of Cardiology in 2019, the LDL, if the patient is high risk, is less than 40. Okay, if we're having second event in less than 2 years. The Indo Society in 2020 is less than 55 if his patient established atherosclerosis a multiple risk factor. The ADA recommendations, they are going with the primary prevention, secondary prevention. Let's talk about primary prevention. If the patient is less than 39 and with additional risk factor, may be reasonable to initiate statin. But if he doesn't have, no risk factor, especially the type 1 diabetes, we might consider other risk factor. We consider him as moderate. But if a patient above 40 to 75 with moderate intensity statin therapy, but if more than 75 years, moderate intensity after discussion with the patient, because we have to weigh benefit risk ratio. If the patient is very high risk, multiple risk factor, like his age between 50 to 70 to use intensity therapy. Patient with 10 years risk, more than 20% is to have to add other than statins, ezetimibe, to maximally tolerate the statin to reduce LDL by more than 50%. What about secondary prevention? So all age less than 75, high intensity therapy, as much patient can tolerate. If the patient more than 75, it's reasonable to continue statin therapy or initiate statin after discussion with the patient. Very high risk. If the LDL more than 70, or maximal tolerated statin, considering adding ezetimibe or PCSK9. So not every patient we add for them PCSK9 if they are very high risk and the LDL above the 70. Okay, the diabetes specific risk assessment, it should be like long duration, more than 10 years for type 2 diabetes or more than 20 years for type 1 diabetes. If they're having microvascular complications like albuminuria more than 30, or they're having GFR is low, they're having retinopathy or neuropathy, or they're having ankle brachial index less than 0.9. So this is considering these are risk factors we evaluate for each diabetic patient. What about the national lipid associations? We have it more or less is going with the international. Diabetes, if they are having 0 to 1 risk factor and no end organ damage, the LDL is less than 100. If they are having more risk factor or end organ damage, it should be less than 70. So the risk factor is the age more than 45 for males, 55 for females, family history of coronary disease, current smoking, high blood pressure, is the low HDL less than 40 for males and 50 for females, end organ damage, retinopathy, albuminuria, or the chronic kidney disease. So these are the risk factors. It should be considered to reach the factor. So with these factors adding to the diabetes, 1, 2 or more will make the target LDL less than 70. If the patient is having just diabetes and maybe he's hypertension or he's a smoker, so we consider it 0 to 1, and then the LDL is 100 target. The atherosclerosis risk category treatment goal is the risk category, extreme risk in general, diabetes and the clinical cardiovascular disease, LDL should be less than 55. Very high risk diabetes with 1 or more risk factor, less than 70. High risk diabetes and no other risk factor, less than 100, and this is the usual. And the classification as well for the European Society of Cardiology is the more or less the same. Okay, and the goal is a little bit because the very high risk is 85, not 70. But very high risk should be less than 100, and the moderate risk is less than 100 or less than it's around less than 100. But they call the high risk, the very high risk is more 50% reductions, which should be less than 55 milligram per deciliter or less than 1.4 millimole. High risk, more than 50% reduction and less than 70 with 1.8 millimole. I have to skip it, and okay. What about the category when you initiate a treatment? So it's very high risk, intensive statin therapy with histamine, and PCSK9 is not close to the goal. High risk, intensive statin therapy and estimate if not at the goal. Moderate risk, moderate statin therapy, increase to intensive statin therapy if not at the goal. So it depends on the risk assessment. We know our target and what medication we should use it, and when we're going to build the doses with the patient or adding on medications. So in conclusion, diabetes remains a major public health concern. Dyslipidemia in particular raised low density lipoprotein, cholesterol and triglyceride level, and how low high density lipoprotein cholesterol are associated with increased risk of cardiovascular. Lifestyle modifications and tackling risk factor is a cornerstone of reducing cardiovascular complications. Lipid management has significant impact in reducing cardiovascular events. Screening for diabetes, pre-diabetes, and other sclerosis factors, including lipid profile, should be at the age of 20 or earlier if indicated. Decide diabetic patients with sclerosis risk category and achieve LDL target as recommended by the guidelines. Initiate statin on the day of diabetes is diagnosed and achieve all the 3 targets at the earliest. Good glycemic control, in addition to lipid-lowering drug, is important to achieve lipoprotein targets. Treat all modifiable risk as per guidelines. Thank you.
Thank you, Dr. Afaf, for this nice presentation. We have some questions, if you may allow us.
Sure.
The first question, what if atorvastatin lead to tripling of ALT? What will be the best alternative, and if there is any difference between hydrophilic and lipophilic statins?
Well, because we can shift the good thing with the statins. If we have adverse effect with one, we could it's not must is that we have it with all the group. We can change it. But the thing is, if we're developing the tripling of the LDL of the liver enzymes, we could reduce the dose and add ezetimibe. Or change to other.
We can add ezetimibe and reduce the dose.
Yes.
Okay, but you don't think if one patient is taking atorvastatin, you shift him to rosuvastatin?
No. As I told you, the good thing with the statin is the efficacy are the same, but the adverse effects are different. So we could shift from one to another.
Okay.
If not effective, we could reduce the dose and having ezetimibe. So we have options with this.
Okay, clear. Regarding the risk of cardiovascular disease in dyslipidemic diabetic patients, Is there any role for antiplatelet as in primary prevention, or statin only is enough?
Well, the antiplatelet, before that was an old approach, should be added on any prevention. But now, no, because we have to think of any antiplatelet to benefit the risk-benefit ratio. So the benefits is antithrombotic, definitely, but the risk could have minimum risk of hemorrhage. So the thing is, the patient diabetic doesn't have risk factor of cardiovascular disease, we don't have to add.
Okay. Is there any priority for any medication over the other in treatment and prevention of dyslipidemia? And how to decide which is the best for my patient?
Yeah, well, because it depends on the studies, and the major studies that we have, cardiovascular, atorvastatin is definitely one of them, but can be used all the others. Statins is the, to start with, statins is. And then we go with the group that we're having, maybe if the patient's having at risk of cardiovascular, maybe atorvastatin is more, but can be anyone can be used.
Okay. The last one, in Eurospire and reality trials showed that only 30 to 40% reached the LDL level target. My question is, can we follow up only with LDL, or do we have to do the full lipid profile, including triglycerides?
Yeah, it's actually full things, but sometimes it's not doable in different hospitals. So we're going with the LDL. But you see, when the guidelines I gave you, it's like apoproteins, the triglycerides, the HDL, and we know the HDL because the graph that I showed, the HDL is important as the LDL. So if the HDL is low, the LDL is high, this is the risk of cardiovascular. So we have to go with all aspects.
Okay, thank you. And please stay with us for your next presentation. And it will be after 1 hour, after we finish with Dr. Ahmed Al-Mutabi. Okay. Now with Dr. Ahmed Al-Mutabi. Dr. Ahmed Al-Mutabi is a consultant endocrinologist and assistant professor. Dr. Ahmed, are you still with us?
Yes, Dr. Ahmed.
Dr. Afaf, if you please, can you stop sharing your screen? Yes, thank you. Again, Dr. Ahmed Al-Mutabi, thanks for joining us. Dr. Ahmed Al-Mutabi is a consultant endocrinologist and assistant professor of internal medicine and endocrinology. We will present today adrenal incidentalloma, and later we'll have an approach to thyroid nodule. Thanks for joining us, Dr. Ahmed. And if you please share your screen and we can start.
Okay, thanks, Dr.